Good evening, everyone. I'm Neil Love from Research to Practice, and welcome to Meet the Professors Live. As tonight we have some general medical oncologists joining us to present cases to our faculty. We're going to start off this evening focusing on multiple myeloma. We have Dr. Sagar Lonial from the Winship Cancer Center at Emory University in Atlanta, and Dr. Shaji Kumar from the Mayo Clinic in Rochester, Minnesota. Then we'll have them leave the stage in about 50 minutes, and we'll talk then about lymphomas with Dr. Ann LaCasce from Dana-Farber and Dr. Loretta Nastoupil from MD Anderson. And then we'll finish out our discussion tonight on CLL, chronic lymphocytic leukemia, with Dr. John N Allan from the Weill Cornell Medical Center in New York, and Dr. Susan O'Brien from the UCI Chow Family Comprehensive Cancer Center in Orange, California. So we've been doing a Meet the Professor series really since the beginning of the pandemic. We've presented over 3,000 cases of every possible tumor type, and we've had dozens of general medical oncologists, gynecologic oncologists, urologic oncologists presenting cases by video. And we brought three oncologists who've contributed many cases to this series to join us today to really query the faculty directly. So from the far side, we have Dr. Lowell Hart from the Florida Cancer Specialists in Fort Myers, Florida, Dr. Eric Lee from the Compassionate Cancer Care Medical Group in Fountain Valley, California, and Dr. Priya Rudolph from the Northside Hospital Cancer Institute in Athens, Georgia. So we're going to start out tonight talking about multiple myeloma. We'll begin with upfront therapy. And before we hear a case from Lowell, a very interesting case of a 39-year-old woman, Sagar, maybe just kind of summarize where we are today in terms of induction therapy in the transplant-eligible patient, the non-transplant eligible patient, particularly the role of anti-CD38, DARA, and what are your usual approaches in that situation?
Yeah, I think that there is a wealth of data out there that really speaks, and I'm going to start with the easiest answer, which is the non-transplant eligible patient population, where I think the DARA-Lendex combination, as evidenced by the Maya trial, really does represent probably one of the strongest levels of evidence establishing a standard in the context of transplant-ineligible multiple myeloma. When you look at the transplant eligible, I think there's a lot of debate about whether the proteasome inhibitor should be bortezomib or carfilzomib. I think many of us have switched to a CD38 plus VRD as our standard induction. There are other centers that say KRD should be the backbone and add a CD38 to it. There are still a few holdouts waiting for not adding CD38 up front, but I think most of us have really moved towards a quad as induction.
Saji, any thoughts, particularly in the older patient? The My regimen is very attractive, but there are other, before that we had sort of RVD light and the potential of doing a quad there. How do you approach the older patient?
So I think the age is not the only factor. So I think if an older patient who has got high-risk disease, who is very fit, I think we'll still try to use a quadruplet. Sometimes you can start them with a triplet and depending on the tolerability, add the fourth drug to that. And that's certainly a reasonable thing to do for the induction phase before we go on to the two-drug maintenance for the high-risk patients. For the standard-risk patients, I think it's reasonable to just stick with the DRD regimen. So
we're going to get into the issue of transplant with this first case, but Priya, one of the things that came up, I met with the docs and we were talking about the cases and things that would bring up. One of the things that you brought up to me is the issue of corticosteroids and the harmful effects that you've seen on your patients. Anything you want to say about that? Any questions you have, Priya, about cutting back on steroids or eliminating? Anything you want to ask about that?
Yeah, so there was a small series of patient study, which I recall comparing DARA-RVD versus DARA-LEN without the dexamethasone. And would love to hear more about the efficacy data and whether that's something we can incorporate, because we do run into patients where steroids can be, particularly diabetic patients. Would love to hear your thoughts and if that's something we can do, particularly if they're standard risk, elderly patients.
So Sagar, curious, again, you have a patient who's diabetic, you're concerned about that. How do you deal with the steroids?
Yeah, I think that there's a lot of play, especially as we have much more active drugs now. If you actually look at that study, they did give Dex, but they only gave it for the first 4 cycles, and then they stopped. And I think most of us, I'm sure Shaji and I would agree on this, we probably use our most intense steroid dosing in the first few cycles of treatment, and then already start backing off, to the point that my patients on Maya, at 1 year, they're not on Dex anymore at all. And so you end up tapering down the len in that context as well. So I think I agree with that sentiment.
Saji?
Yeah, I completely agree. I think, in fact, I think even earlier than a year, I think there's the Italian trial which looked at discontinuing dexamethasone after 9 cycles completely and decreasing the dose of lenalidomide with in fact, maybe better outcomes. So I think most of us tend to use, again, 20 milligrams for those people over 75 to start with, and then taper it off quickly by 9 cycles.
So let's get into real cases. One of the things that's so informative is, it's all well and good. You put up a case, and say, whatever, 39-year-old patient. You don't really have a feel for the complexity of how this plays out in practice. And Lowell, I think your patient's a good example of that. Can you kind of summarize what the issue is with this woman?
Sure, Neil. Yeah, she's 39. She was diagnosed about not quite 2 years ago. Moved over to me on the West Coast from Florida, previously had lived on the East Coast. Has had a very nice, has no high-risk features, is doing great. She started off on RVD, and then we went to a quadruplet. Eventually, now she's on Dara-Len-Dex, has just a small monoclonal spike left, and especially at her young age, I have sent her to several academic transplant centers around the state, and it's just been difficult for her to mesh with any of the people in the centers that I've sent her to. Not that they've done anything wrong, it's just personality-wise, she, I believe, has an anxiety disorder. So this brings up the question, we certainly have patients in the real-world setting that are not in perfect psychologic condition, that have underlying disorders, as you know, mental health and a bad cancer is a tough combination to deal with if there's 2 different diseases going on. So she doesn't totally accept that she has any psychiatric disorders, but I think she does. So it's been difficult to get her to mesh with the transplant center. So I guess my question is, if I cannot ever get her to get an autograft, what would we do for maintenance? She's done extremely well. She's in a VGPR, at least at this point. Would they just continue the same thing, forever, just put her on Len-Dex, you said taper off the Dex, what should we do long term? I'm still hopeful that I can eventually get her to transplant, but it's been quite difficult.
So Saji, first, what would you do if you can't get her to agree to transplant?
So 2 things. I think one is we'll want to try and at least collect the stem cells and store it for a future transplant. And second is to give them about at least 9 cycles of the injection therapy and then go to Len maintenance, given that this is a standard risk patient.
And Sagar, the other question is, how hard do you push for transplant? We saw the determination trial. There wasn't survival benefit, but we were talking before. Maybe you can elaborate a little bit on your, how you feel about transplant at this point after having seen those data.
Yeah, I think that there are, looking at overall survival in the determination trial is, it's not the right time to look at it because the follow-up is so short, and we know that on average, the median survival of a myeloma patient is over 10 years based on the RVD 1000 series that we published in other data sets. And the second is, determination was never powered for overall survival. So it's possible there could be a difference, and we're just not going to see it because the numbers are not large enough that was designed for that. It was designed for PFS, and it was a home run by PFS. 22 months improvement in PFS, which I dare you, at ASCO, find a study that is a 22-month improvement in progression-free survival. There aren't many of them. What worries me more, and you could argue I'm guilty of anecdote here as well, but I've seen lots of patients in the last few years that somebody from around the country said, you don't need a transplant, you can wait. They're now on 3rd-line therapy at 4 or 5 years, and the median PFS in IFM was 5.5 years. So in theory, you have now gone through 3 cycles of therapy when you could have only still been on 1, on average, had you had a transplant. So I would push if you could, but you can't with everybody.
Have you seen patients, Sachi, who've been able to stay on maintenance for prolonged periods of time, standard risk disease?
Absolutely. I think the standard risk patients, you certainly, again, the best approach would be to take them to transplant. If you can't, they still manage to continue on, with maintenance therapy, they can control the disease for long periods of time.
And we should also bring up the issue of high-risk disease. Sagar, how do you approach those patients?
Yeah, I mean, those are patients where the benefit is even much clearer. I mean, remember, in Europe, patients with high-risk myeloma are getting tandem autos. I don't think you need to do that if you use triplet-based maintenance, which I think many of us have adopted for high-risk myeloma. But in those patients, the window of benefit is much bigger for a high risk than it is even for a standard risk.
Sachi, what specifically is your maintenance approach to a high-risk patient?
So for the high risk, we predominantly using a proteasome inhibitor and an IMiD combination for the high-risk patients. Usually it's bortezomib and lenalidomide because most patients are on a DR-VD combination for induction therapy, and then post-transplant we use VR. But if somebody is on a carfilzomib backbone, then we can certainly use the carfilzomib and len combination for maintenance.
Any interest in ixazomib, as an oral agent, more convenient for patients in the long term and maintenance?
The phase 3 trial did not really show that much of an improvement with the ixazomib versus observation, just only a 5.5-month improvement. And compared to what we have seen with the len backbone maintenance, that is very inadequate, I would say. And we don't have enough data with the ixazomib len, even in combination, to be used as maintenance instead of one of the other combinations.
So, Priya, can you talk a little bit about your 77-year-old man with standard risk disease?
So it's a 77-year-old gentleman who was a previous golfer, very active gentleman, presented with generalized weakness. Further evaluation, turns out he has a lambda light chain amyloidosis with T1114 translocation, and I've been coordinating his care with our transplant team. Their initial recommendation was to do about 4 to 6 cycles of dara-VCD, followed by a stem cell transplant, followed by dara maintenance. He's had a few complications relating to myeloma. He is very hypotensive. His systolic blood pressure hangs out in the mid-70s to 80s. Went in for a complete hospitalization cardiac evaluation. He does not have systolic dysfunction. Cardiologists actually seemed to think he was doing fairly well from a cardiac standpoint. The understanding was the blood pressure issues are probably related to autonomic neuropathy from amyloidosis. My bigger question and his concern, of course, is how much of this is reversible, particularly from just an amyloid complication-related standpoint, blood pressure issues. Will he ever get back to his normal baseline? My questions for him is how effective is transplant in providing a quality of life in the long term, reversing some of these complications, and B, what is his long-term treatment plan? So is transplant completely necessary in his case? And after transplant, what is maintenance therapy? What should we look forward to as far as remission rates and or complications and future progression?
And also, Sagar, is there kind of an age limit, even in a very functional patient? What's the age where your group stops doing transplant?
Yeah, I think, at our center, 78 is probably the point at which we start to really say no. 75 is where I start to think twice about it. In a patient with amyloidosis, I think, and again, I'm curious with Shaji's opinion on this as well, but certainly dara-VCD has a really good track record in amyloidosis. And if they achieve a complete remission with normalization of the light chains, in a 77-year-old who's got secondary complications of amyloid, I probably wouldn't transplant that patient. I mean, if they've achieved a normalization of their light chain ratio, that's pretty good. And in fact, for a lot of these patients, we don't give them maintenance either. So, I mean, once you achieve, it's not like myeloma in that sense, it's different. And so I might argue if you can get him numbers better and then give him time off therapy to see if his amyloid-related toxicity reverses, you might have a win in a 77-year-old. I'm curious what you...
No, I completely agree. I think the transplant is being used less and less for these amyloid patients. And I think somebody who is 77 with cardiac involvement, with significant systolic, low blood pressure, is really a very, very high risk for treatment-related mortality with transplant. So even if he was like 65 with those significant cardiac involvement, with significant drop in low blood pressure, I might not take them to a transplant. So the DARA VCD for 6 cycles, and then doing the daratumumab alone for an additional 12 to 18 cycles would be the best treatment. Now, having said that, it always has to be in the context of the response. So if somebody like him, if he's got a hematologic complete response, nothing else needs to be done other than completing that therapy. Let's say 6 cycles into the treatment or even 4 cycles into the treatment, you're not seeing a hematologic response. In 11-14 patient, we might think about using a venetoclax-based combination in those patients.
And speaking of venetoclax, Sagar, can you comment on where you start thinking about venetoclax in patients with myeloma T11-14 and how you use it?
Yeah, so I mean, in a more straightforward case than this one, although there are trials looking at venetoclax in amyloidosis, I certainly, for 11-14, I start thinking about using it in first relapse. And it's not, I've got a whole stable of patients, if you will, that didn't have a great response to RVD or DARA RVD. I put them on Ven, got them into a great response, transplanted them, and then actually I've got a few that I'm using Ven maintenance in. So I try and move it as early as you can, because the more complicated the genetics get, the less potential benefit you may get.
And you're talking about Ven alone or Ven in combination?
So it depends on the clinical situation. If they're late line and they've seen everything, I'm probably going to do Vendex. But if they're earlier lines, I might partner with DARA based on some data that's been presented, or partner it with a proteasome inhibitor, again, based on some published data. But this is all sort of off the reservation.
Saji, again, venetoclax in 11-14.
Yeah, I think I agree with Sagar. I think for me, maybe I might use it at one more cycle, one more line of therapy later. I still prefer to use some of the triplets from the phase 3 trials for that first relapse, and then use the venetoclax-based combination for the subsequent line of therapy. So again, predominantly with either daratumumab or carfilzomib, based on what they may have seen in that previous 2 lines of therapy.
So Eric, let's hear another case. You have a 55-year-old man. Can you talk about what happened with him?
Absolutely. 55-year-old man, standard risk IgG kappa myeloma, achieves a very good partial response on RVD times 4 cycles. I referred him for transplant. The transplant team actually felt that he needed additional cytoreduction and recommended switching him over to Dara-Lendex. And so I switched him over. He remained in very good partial response after 4 more cycles, and I sent him back for transplant. He was worked up at the transplant center for about 6 weeks, cleared all the testing, but they tried to mobilize him, I believe twice, 2 weeks apart, and were not able to obtain adequate stem cells. So he was referred back to me to resume Dara-Lendex effectively indefinitely. And so my question is, and in this case, I actually repeated a bone marrow for him when he came back to me. So it was about 8 weeks after he left me to do his transplant workup. And his repeat marrow actually showed that he had cleared his marrow. He was in a complete morphological response. I did send off for an MRD. It was MRD positive. His M-spike had cleared. His light chains had normalized. And so my question for the investigators is, would you move on to a maintenance regimen for this patient? Would you actually complete your 6 to 8 cycles of DRD and then go to maintenance?
So Sagar, how often do you find situations where you can't collect cells?
Well, I think in the era of quads, we're seeing that we're collecting fewer cells than we could before we started adding DARA in. I've had a few patients where we got maybe 1 or 2 million cells, and I like to shoot for 8 million. So we may have to recollect them, or we don't get what we want the first time. I give them a few weeks off of everything and then try and remobilize them again 2 to 4 weeks later, sometimes with cyclophosphamide, sometimes without, depending upon how close I am to getting where I want to get. So we are seeing this more and more often. I've not had a patient I couldn't collect at all. But certainly, if you were struck with that kind of a clinical situation, I would try and mimic the trials that give me the most data, which is typically between 4 and 8 cycles of induction and then switch to maintenance. It sounds like this guy's already gotten where you want to get him, so I think switching to maintenance is a reasonable idea.
Saji, anything you want to add to that?
No, I think it's the same thing in terms of, I think we have to try and, in this patient, making one more attempt to collect the cells is going to be important. And this may be the best time to try it when you're kind of transitioning from that induction to maintenance. Even if the person doesn't want to go to transplant, collecting the cells for somebody at 55 years of age is going to be important.
So I'm curious also, we've been talking about quads, and Sagar, I'm wondering, we're starting to see data with isatuximab in the upfront setting. I'm curious where you see things heading in terms of ESA, also in terms of delivery of anti-CD38 and sub-Q. Now we're seeing a new device used with ESA for sub-Q. Any thoughts about where that's heading?
Yeah, I mean, I think the ESA plus triplets data looks very compelling. Do I think it looks appreciably different from the DARA plus triplets? I'm not sure that it really is quantitatively different, but I think from my experience, you want to pick your agent that you're used to using and just stick with that so that you anticipate what the adverse events might be and know how to handle that. If you can get sort of an Onpro-like, I think is what they're doing now for ESA, that's certainly a reasonable way. It's a lot easier than an infusion. The sub-Q DARA is just pretty convenient for many patients.
Shaji?
Yeah, no, I think the data looks good. I don't think there's anything to distinguish between the two. I think the main thing right now is the route of administration. And once we have that on-body device available, it's a pretty even playing field there.
Have you used that new device? And
no, it's still going through
it's
trials.
It's still being evaluated. I guess that was reported at ASH. Was it last year? I lose track of the sub-Q device.
Right.
Right. Okay, let's go on to another case, and of course we want to get into the issue, particularly of bispecifics, also update on CAR T. And before we get into a case on that, just curious, can you give us a little preview, Sagar, of the CAR T paper that's going to be presented here?
Yeah, I mean, I think we've seen a lot of data. Some of it is around real-world data with CAR T cells, and I think what is encouraging is that the real-world experience looks not dissimilar from what we saw in many of the clinical trials. Many of the patients enrolled in the real-world experience perhaps wouldn't have qualified for the clinical trials, but certainly seeing that the data on response, depth of response, it's probably a little too early to really comment on PFS, looks similar to what we've seen before. I think the other data set that we're waiting to hear in the next 48 hours is the late-breaking abstract on CARTITUDE-4, which is looking at cilta-cel versus 2 pomalidomide-based approaches in 1 to 3 prior lines of therapy. And we know from the Wall Street Journal, the great medical magazine, that at least we're told that it's a positive trial favoring CAR T cells. We don't know what the difference looks like yet, but certainly that's something to be really excited about as well.
I don't know if it's too naive a question, Shaji, but any thought about whether, because you see this in lymphoma, we're going to talk about it later, any thought about the possibility of CAR T coming before transplant?
I think the clinical trials are specifically looking at that, but what we learned from the KarMMa-3 trial, at least with the ide-cel, is that, granted it's 2 to 4 prior lines of therapy, is that you see the patients continuing to relapse over time, which is a little bit different than the lymphoma story. So I suspect we are probably not going to get to that cure fraction, maybe at least yet, with at least using them in that first relapse setting. Can we do that for the newly diagnosed if you move it really upfront? I think we really need to wait and see.
What's the current situation, Sagar, in terms of being able to access CAR T? And if you are able to access it, any preference in terms of the 2 therapies?
Well, I think the access piece is improving for both commercially available products now. If you'd asked me that 6 months ago, I would have said we're still pretty rationed in terms of the number of slots we get, but I think both are opening up pretty reasonable numbers. I think as we're starting to see these randomized trials, we get a better sense for how these products perform beyond that refractory myeloma patient population, where sometimes the populations may not be exactly the same to compare. But I think what we're starting to see now is that with cilta-cel, it looks like we're seeing somewhere around 30 to 36 months. With ide-cel, it looks like it's a little bit shorter, at least in the trials we've seen, but we have not seen a huge number of phase 3 trials.
And what's happening in terms of, at one point we were hearing about Parkinsonian-like issues with cilta-cel, Shaji. What happened with that?
Seems like the incidence of that is much lower if you were able to give good debulking therapy and patients go into the treatment with low disease burden, then it certainly seems like it's much less frequent.
Any thought, Sagar, where, if you are able to end up, perhaps as a result of this trial, being able to use it much earlier, kind of what you think sort of the sweet spot is going to be? And also, any thoughts about, you mentioned the fact that it doesn't seem to have that shoulder that you see on particularly a diffuse large B-cell lymphoma, what it'll take to get to that point?
Yeah, I think to me that's the really big and important question. And when you ask about replacing transplant, let's say 36 months is what we see with a CAR. Remember, the median PFS from determination with a transplant was 65 months. So that's a lot longer. And if you're a standard risk, it's closer to 80 months, 80. That's a pretty high bar to get over. And so I think what it's going to take, at least in my view, to move CAR earlier than perhaps first relapse, where I'm anticipating we're going to see positive data, is some way of improving persistence or maintenance therapy. And what I'm hoping is that if we do maintenance post-CAR, it's very limited duration maintenance. It's not continuous like it currently is post-transplant.
Are you thinking that we're going to end up in using CAR-T in first relapse?
What was that?
Are you thinking that we're going to land in first relapse as when we're 2-3 years from now?
I'm anticipating that we're going to see data that suggests that using it earlier, it's better than what we have in first relapse. I think it still becomes a patient-driven question about would they rather take something that's completely outpatient or take the 2-week hospitalization with a CAR, depending upon what the PFS ends up.
And so in a second, I want to hear about Eric's case of the woman who got turned down for CAR-T because of cardiovascular issues. But Shaji, just sort of broadly, when you think about what eligibility for CAR-T compared to eligibility for autologous transplant, who are the kinds of patients who would be eligible for CAR-T, but you wouldn't send a transplant because of, comorbidities, age, et cetera?
I don't think the age is as much a factor as much as, probably the cardiopulmonary function is probably the most important, the ability to withstand significant CRS if it were to develop. And then the other main thing would be, again, significant neurological issues going into it can make the whole thing much more difficult to monitor during therapy for complications. So barring those two things, if the person's functional status is reasonable, we can certainly take them to CAR-T. And we have been taking patients up to 80 and older to CAR-T therapies, as long as they are in a good shape.
And just to add on to that, and of course, the number one question we get from oncologists right now is about bispecifics. Again, Sagar, kind of what's the bar to be able to give bispecifics in terms of age and cardiac function?
Yeah, to me, I think about, can this patient deal with grade 2 CRS? That's really the benchmark that I look for. If I'm not sure, I may send them to our cardio-oncologist and ask them, what do you think about, could they handle 2 liters of fluids over an hour and a half? But if they can pass that bar, then from a cardiac perspective, I'm pretty good.
What about prior neurologic problems, prior stroke, et cetera, or CVA? Shaji?
I think, as long as there is no significant cognitive issues that could, again, cloud the ability to assess for neurological problems, I think it's fine. Somebody who has had a previous stroke doesn't necessarily exclude that patient completely from getting a bispecific. I think I would be maybe a little bit more worried with the CAR-T, but again, I think it's more the kind of symptoms that you would, any significant level of dementia or other neurocognitive disorders would be more concerning.
Do you really see neurologic issues with bispecifics?
You can get some, usually less than 10% from across the bispecifics in terms of any neurological symptoms, not necessarily, the ICANS as we see with the CAR-Ts.
Yeah.
And, we're just chatting here tonight. We're making rounds. There are a lot of great slides in our slide set if you want to look it up, but I'm kind of want to try to get the clinical bottom line here. So let's bring in your case, Eric, as we go back to the real world.
Sure. 60-year-old woman, standard risk myeloma, had completed VRD, progressed, transitioned to DRD, and was starting to progress. I actually referred her for CAR-T evaluation. And during the workup, there was an abnormal EKG. She was managed care, so she got sent back to me in the community. I sent her for cardiac workup. She ended up getting a cardiac cath, and actually, they did not recommend stenting, so ended up recommended medical management. referred her back to CAR T Center, and they did not recommend CAR T. So I have her on carfilzomib Pomdex right now. The best she's able to achieve is a partial response. Looks like teclistamab requires 4 lines of treatment, so she needs to go on something else next, selinexor maybe. And based on what Dr. Lonial just said, it sounds like, her cardiac workup showed an ejection fraction of 45%, if I remember correctly. So she might not be the best candidate to blast with fluids in the setting of a CRS. But my question is, I was going to ask whether to be a candidate for teclistamab in the future.
So Sagar, any thoughts? And also, how many lines of therapy, how many therapies do you need to be able to give teclistamab?
Yeah, I mean, I think actually for the bispecifics, you need to have had 4 prior lines of therapy. I think just to put that 45% EF in context, I've transplanted people with EFs of 30% or lower. So 45 is fine with me. As long as they're compensated and they're functional and they're up doing what they want to do, I would think about it. But TEC or a CAR would be a reasonable thing to consider for both.
So you think it's likely another CAR center might accept a patient like this?
We would. I'll give you our number.
Lowell, you had a question?
No, the question I was just going to ask was about the practical question about MRD testing and what sort of these settings is that really useful and something that is it just being followed in the post-transplant setting, or are you following it, try to look for somebody who's going to relapse earlier, tell their prognosis, or is it useful in a non-transplant setting?
Saji?
Yeah, no, I think what is very clear is it's prognostic in value, and I think knowing somebody is MRD negative, we know that the outcomes are going to be better. Having said that, what we don't have data is to show if it's an actionable finding. So somebody is MRD positive, giving them a different treatment, trying to make them MRD negative is going to improve the outcomes. Now, having said that, in patients with high-risk disease, we know that one of the best things we can do for those people would be to get them to be MRD negative. So I think most of us tend to use that information to change therapy or intensify therapy for those patients with high-risk disease. Typically after that, or after the transplant, to ask the question, do we do additional consolidation therapy? Do we change treatment? Those would be the only scenario where we would typically use that for changing our treatment approach.
I want to hear what you all have to say about, from practical point of view, the use of bispecifics, particularly teclistamab. But first, can you kind of paint a little bit of a picture of the agents that are most far along right now, Sagar, the bispecifics, the difference between them, and where you see things landing in the next few years?
Yeah, I mean, there are 6 BCMA-directed bispecifics that are probably in development. One is approved, teclistamab. Second one, elranatamab, is probably not far, we hope, from being approved. The other ones, my main difference, at least when I look at them on the surface, is not on response rate. PFS, it's hard to know because we don't have a long enough follow-up. It may be on the frequency of administration. So we know that most of them are once a week. There are some that are every other week. There's one that's every 3 weeks. So I think that may be one area where things fall out differently. What is, to me, really interesting about, if you're talking about purely bispecifics, is there's some resistance data emerging suggesting you get mutations in BCMA binding. And that may ultimately result in resistance. But if you're resistant to one, you may not be resistant to another. And so where the second one binds may be different than where the first one binds, meaning you may still be sensitive to a different one. So that to me is really exciting. And then just to wrap it up, there are 2 non-BCMA targets, GPRC5D and talquetamab is probably the furthest along, and then FCRH5 with cevostamab being the furthest along.
What about the combination of non-BCMA and BCMA together? I think there's a paper here looking at that.
Well, we saw some data reported at ASCO combining BCMA and non-BCMA targeted approaches, and the response rates looked off the roof. I mean, I think it was 90+% overall response rate. I think what we have to understand is that these BCMA, any T-cell engager is going to skew your T-cell population one way or another, and what impact does that have on infections and other things along those lines? That is a big issue with BCMA-directed bispecifics, and so understanding the dose and schedule and prophylaxis is going to be really important.
Yeah, can you comment a little bit more about the issue of infections, both with bispecifics and CAR T, and also cytopenias, Sachi?
Yeah, so the infection, I think, seems to be the major, signal that we have to worry about with the bispecifics. We are seeing 30+% grade 3-4 infections across many of these studies with the bispecifics. Obviously, part of it is because these are advanced myeloma patients who are obviously more susceptible to infection. But having said that, clearly that is uncommon infections that we typically don't see in the myeloma patients. The opportunistic infections clearly suggest that there is a component that is attributable to the therapy. We do see increased infections with CAR-T as well, but one of the things that we do see with CAR-T is a prolonged cytopenias. Almost a third of those patients can have persistent cytopenias, which may take up to 6 months to recover, which is not something that we typically see with the bispecifics. We may see some in the beginning, but they generally seem to settle down. Right. So I think the infection risk, it seems a little bit more with the bispecifics as we continue to keep them on therapy. And then the cytopenias may be a little bit more with the CAR-T.
Priya?
So as far as infections, do you keep them on prophylactic antibiotics or antivirals, or the combination of two, and how about IVIG, and what point do you institute those?
So with our own practice of the bispecifics, we monitor the IgG levels, and as long as it's under 400, we do give IVIG for those patients. They are all on antiviral prophylaxis, typically with acyclovir. They're on PJP prophylaxis. Some of us tend to, again, if someone comes in with quite a few very frequent infections, then sometimes we put them on quinolones, at least in the initial couple months until the myeloma is under better control, and then we can pull back on those.
So I'm curious, Lowell, kind of how you and your group are getting geared up to use bispecifics like teclistamab. Are you just sending them to your tertiary center and letting them deliver them, or are you hoping to be able to deliver it yourself?
Yeah, currently that's what we're doing. Obviously with bispecifics, the frequency and the need to keep traveling back and forth to the tertiary center is a big limiting factor in community practice, and especially if you're not in the same town. So we're starting to look at, with a couple of our more sophisticated hospital systems, and with some of our younger doctors too, about coming up with some way to give this in the community setting. I anticipate the next couple of years will be, geared up to do that. The main thing is you have to make sure, thinking about it practically, that you have doctors on call that understand CRS and that you have the facilities in the hospital available. I think it is quite doable in a sophisticated community setting if you're set up, but it could take a little work for anybody who wants to do it in practice. I don't know if other practices are already doing it, but I think we're probably a year or two away from being able to do it.
I'm wondering how many places actually carry tocilizumab. What are some of the discussions that are going on right now, Sagar, in terms of where this is going to head and how community docs are going to be involved with bispecifics? Do you think I've heard people talk about, well, maybe the first couple doses would be in a tertiary center, then they could come back. What's the typical course in terms of tolerability, particularly CRS and neurologic problems?
Yeah, typically if you're going to see CRS or neurotox, it's going to occur in the first few weeks. And so there are many where we will get it started and then we'll send them back to their doc for continued dosing. I do think the infection prevention and monitoring is a big deal, and if your practice isn't used to doing that, it's a hard rhythm to get into early on. But we are looking now at preemptive dosing, for instance, with tocilizumab to prevent significant CRS, to allow us to move it to the outpatient setting. That's been done with cevostamab, it's being done with teclistamab. So we may see some emerging data on how to do this, but there's still going to be a risk that somebody's going to break through that preemptive therapy. And then how do you manage them at 3 in.the morning, which is when this almost always seems to happen.
Yeah.
You were talking about resistance, Sagar. You foresee the time when we'll actually be able to do assays, look at the type of resistance and tailor the therapy based on that?
Well, I hope so, because obviously that would be really helpful. I think what's interesting in myeloma is that, let's say you're progressing on a BCMA-directed bispecific. Right now, you certainly have the potential for switching targets to GPRC5D or using FcRH5. But the ability to revisit a target like BCMA, which we know is so important for plasma cell survival would be nice. And so sequencing to understand if there's a mutation, is it sensitive to one of the other 6 BCMA-directed, that may be a nice thing to have in your pocket if you want to come back to BCMA down the road.
I'm blocking on the name of the drug. It's used with desmoid tumors as a class of drug to try to increase the amount
GSI.
of GSI. Can you explain what that is? And the story with the desmoid is amazing, but you're using the same thing to try to increase BCMA?
Yeah, so gamma secretase is the, oh, I'm sorry, no, okay, is the enzyme that cleaves BCMA off the surface of a plasma cell and releases it into the serum. And so that's where you get soluble BCMA from. And a gamma secretase prevents that enzyme from working, and then you significantly upregulate BCMA expression. So using that may resensitize cells that are resistant because of low-level BCMA expression. You may make them high-level again.
Is that an active thing that's being pursued? I know you presented on that, I think it was last year, right?
Yeah, I mean, it's being looked at with belantamab, it's being looked at with CAR T cells, it's being looked at with bispecifics as well.
So speaking of belantamab, would you like to give us a little bit of an update, Sachi? I was personally pretty surprised when it got pulled off the market. We were doing an education program where we were doing videos, and I had videoed a patient who had a 4-year response to belantamab. And there are people out there, and now it's not available. Any thoughts about that? And you see it coming back?
Yeah, I think there are clinical trials that are looking at the phase 3 trials ongoing with combinations. I mean, we had the DREAM2 study data that was presented at yesterday's session. I mean, clearly, against pomalidomide dexamethasone in that group of patients, it was not superior. Certainly was not inferior. And we all have experience with patients who get responses, and they have really durable responses with belantamab. So I think that drug clearly has activity in patients. The 2 key things is obviously, one, how do we get over that corneal toxicity issues? There are a lot of studies looking at different schedules, so giving it every 12 weeks might be one way to get around it. Especially if you're going to give it every 12 weeks, then we will definitely be using that in combination. So some of the phase 3 trials looking at the proteasome inhibitor and IMiD combinations clearly will determine how we're going to end up using that drug in the future.
So in a second, I want to hear, Lowell, about your Jehovah's Witness. But just one more point, Sagar. Eric brought up the fact that they were thinking about selinexor in his patient. I'm curious to where things are with that agent. Do you use it, and what situations and how?
Yeah, I think the challenge with selinexor early on is that its approval was at a dose that's really ungivable. I think the twice-a-week dosing with Dex just it's a very hard regimen for patients to take. Now, when you switch to once a week and you start to partner it with other drugs, then it starts looking very different. I like to partner it with a proteasome inhibitor, whether it's bortezomib or carfilzomib. Many in my group like to partner it with pomalidomide. I don't think it matters. Just get used to dealing with whatever the adverse events from your partner combination is. If you partner it with an image, you're more likely to have significant cytopenias, which can be an issue with selinexor in and of itself. But I think it does have activity. And it certainly has activity in a post-BCMA world where many of these patients who are progressing on either CAR or a BCMA bispecific can be sensitive to selinexor-based combinations, and that might be an option.
Saji, any thoughts?
Same thing. I think the key thing is just understanding that you have to start at a lower dose, give it once weekly, and my own preference is always to use it in combinations, preferably a proteasome inhibitor.
So again, before we get to this case that Lowell has, we have a case from the audience. Sagar, 78-year-old with T1114, got initial 4-drug therapy, couldn't tolerate the Len even at 5 milligrams because of severe rash, progressed on first-line Dara-VD, then progressed on venetoclax Dex. What's next? Do you give up on venetoclax, or could you add something to that? Any thoughts about this case, Sagar?
Well, if they're progressing on venetoclax and Dex, I'm not sure you're going to be able to resalvage them by adding something else in. We do know, the longest patient I had on Ven as a single agent was almost 6 years. And when that patient progressed, we added Dex and didn't really get much more mileage out of it. And that patient had shifted from BCL2 dependent to MCL1 dependent, which is not going to really work very well for venetoclax. So I would think about looking at other drugs the patient's not had. It doesn't sound like they've had carfilzomib. You could think about, I don't remember whether Dara was on that list, but there certainly are things you could do.
Sachi, any other thoughts?
Yeah, and again, this was, if I remember correctly, 78 years
Yeah,
old?
mhm.
Okay. So, I mean, a younger patient you could have who hadn't had a transplant certainly could consider a transplant because the 11-14 patients do very well with transplant generally.
What do you see when patients with venetoclax in terms of tolerabilities? Do you see GI effects? Do you see cytopenias?
It's a mix of cytopenias and GI issues, predominantly with the venetoclax. And again, a lot of the studies have been done with the 800 milligram dose, but most of us, I don't think, goes beyond the 400 milligram dose, both in terms of the tolerability and the pill burden. And most of the patients whom we are using the venetoclax with Dex or with any of the other drugs 400 seems to be sufficient.
And Sagar, I've never heard anything in terms of TLS with myeloma and venetoclax.
No, I mean, we at one point were checking an LDH later on in the afternoon after the first dose, and if we saw any bump, we were worried, but we've not seen it at all.
Yeah, I haven't seen any.
All right, well, let's see if we can finish out with your patient, your Jehovah's Witness patient, your 70-year-old man.
Yeah, he's a very nice 70-year-old gentleman. We presented about 18 months ago after a fall, was found to have lytic bone disease. His marrow had about 30% plasma cells and a 13Q. He had some light change in his urine also. He had a humerus lesion which needed a little radiation, and then we started him on an RVD. He had a nice response to that, and then a few months ago he had at least a VGPR, and then he started to get a little bit worse bone pain. He got some neuropathy also, and his protein level started to increase, so we switched him to Darapom Dex, which he's on now for the last few months, good tolerance, and he's responding well. So, my question with him, his religious faith as a Jehovah's Witness is such that I was told that he is not a candidate for either transplant or CAR T. So my initial question when I was speaking with Dr. Lonial a little while ago was whether he'd be a candidate, potentially for anything else. But it was helpful talking about the case, and perhaps we could talk about it a little bit more with a patient like this.
So Sagar, what's your experience? You were saying that you have a center for this bloodless therapy?
Yeah, we started probably 15 or 20 years ago transplanting Jehovah's Witnesses, and most of them are willing to accept a stem cell product as long as it's a closed system and it's never
their own stem cells. Right.
And so what we ended up doing was saying, we're not going to transfuse you at all. Are you sure this is really what you wanted? And I think we published on that. Dr. Joseph from our group published on our series. There's a group in Pennsylvania at Penn State that's published on this as well. But a bloodless transplant is very feasible. And my best example of a Jehovah's Witness was a 40-year-old woman who presented with renal failure on dialysis. She didn't reverse her renal failure when we got her into remission, but she had a transplant, bloodless transplant. We never got her hemoglobin up where we like to, but because she was on dialysis. But she was in remission for 8 or 9 years, and then finally the nephrologist said, "Can we transplant her and give her a kidney?" And we said, "Sure." So now she's 5 years out from a renal transplant, 12 years out from an auto transplant, not on any therapy, doing well.
Any questions, Lowell?
Well, that was the main question, and I guess bispecifics, I know with CAR T, obviously most of the CAR T patients, I assume, would need or there's a good chance they would need transfusions at some point. What's been your experience with BiTE technology? How often would they need transfusions afterwards? Would it be feasible to do?
I think our experience has been definitely not anywhere near what we see with the transplant. One of the difficulty in comparing them is because most of the patients we're giving bispecifics have really advanced myeloma. They come in with anemia because of the advanced disease, so it kind of sets them up for needing something.
So I'm curious where you see things heading, and I'll see if the docs here have any questions they want to bring up. But Sagar, what are we going to be seeing over the next couple of years in myeloma? What are some of the trials that are maturing you're most interested in seeing? What are some of the new therapies coming out that you're most excited about?
Well, I think we're going to see the randomization that you asked about earlier, which is transplant versus CAR. I think we're going to see the bispecifics moved into frontline therapy, either with or without an anti-CD38 antibody. But at least in my mind, we should have the tools to ultimately cure a larger fraction of patients than I think we historically have been. And the challenge is up to us now to say, how are we going to combine these drugs in a rational way that ultimately eliminates the clone and use things like MRD to make decisions on treatment. We're not there today, but I think getting the data to answer those questions is going to be really the future.
Before I ask Sachi to elaborate, and I think Priya has a question too, you said cure. Do you mean really getting rid of the disease or more of a functional CML kind of cure, just keeping people alive long enough to die of something else, Sagar?
Well, I mean, I would argue there are a percentage of patients that are functionally cured, as you just described, but there are patients that have not been on therapy for 10 plus years and nothing has come back. Now, if you're 75 and you're now 85 and your myeloma's not come back, are you cured? I don't know. But if you die of something else, I think you can make the case that that's a cured patient.
Priya, you had a question?
So as we're getting ready to administer teclistamab in the community setting, how important is it for us to have tocilizumab? I understand it is very expensive to house the drug. And number two, I read somewhere that if you give tocilizumab, the moment you see CRS, the chances of preventing a future event is smaller compared to dexamethasone. Is that true?
Sachi?
No, I think it's important to have tocilizumab. I think that's an absolute must because of the CRS, which can, again, bispecifics mostly grade 1, 2, but it can definitely be CFU grade 3 as well. In terms of the second question, I wasn't sure what.
Does giving tocilizumab as your first therapy for CRS prevent future events much better than, say, giving them dexamethasone,
No.
particularly in the community setting where you may not have tocilizumab?
Yeah, I mean, the chances of it happening again after with the subsequent doses are pretty small, but whether you use dex or toci or both in the first treatment doesn't have any implications on whether it's going to happen or not.
And you can certainly give multiple doses
Yeah.
of toci. So.
And anything you want to add to what Sagar was saying? I was interested by him predicting we're going to be using bispecifics up front. Any other thoughts about where we might be heading, Sachi?
Absolutely. So I think the bispecifics have a higher chance of being incorporated more widely in the upfront setting. The other thing I think we hope would happen in the next couple of years would be a limited duration of therapy. I think kind of shifting that paradigm from continuous therapy until disease progression to something that's more limited. And I think bispecifics and the immunotherapies are probably the best candidates to help us get there.
Yeah, once the CLL people started talking about time-limited therapy, everybody else started to think about it as well. We're going to get to that in a little bit. So Sagar and Sachi, thank you so much.
Thank you.
So we're going to move on now and talk about lymphomas. We have LaCasce and Dr. Nastoupil. And of course, we just saw a pretty interesting presentation on Hodgkin lymphoma. I'm pretty curious to hear what they have to say about that while they're sitting down. I'm just kind of curious where things are. One of the things we're hearing a lot about, Lowell, is chemotherapy shortages. How's that playing out right now in your practice, and to what extent is that relevant in patients with lymphoma?
It's bad. It's bad. I mean, I have a patient with a, head and neck squamous cell carcinoma was supposed to start cisplatin, and my nurses told me last week they may not have it for him next week. So, because they said they may be completely 100% out in the middle of the week. I think it's a potential disaster, especially for, I don't know how it is in other parts of the country. I also work at an academic center at Wake Forest, and they're in a similar spot to what we are in Florida. So I think everybody, you've probably all heard, they should contact your politicians and say this is a big scandal. I mean, what about women with ovarian cancer? What about young males with testicular cancer? If we don't have curative treatment for these people, it's a disaster. So I would strongly suggest everybody call their congressman.
Yeah, we did a survey of 75 general medical oncologists for some of the other programs we're doing here this weekend, and that was a gigantic issue. Everybody was bringing up, like I said, lung cancer also as well.
Right.
Well, so welcome, great to see you. So we're going to talk about some cases and also talk about data sets, and I guess we ought to just start right out with the maybe one of the biggest stories coming out of ASCO, which is first-line therapy of Hodgkin lymphoma. And Ann, of course, the last few years, we've seen the adaptation of AAVBD, and just at the point, right, wasn't that long ago, we saw survival benefit. Everybody was, it seemed like everybody was on board, and now this afternoon, we see this study here using Nivo AVD as opposed to BV AVD, and hazard rate for progression of 0.49 pretty interesting and impressive. Any thoughts about what that's going to mean, Ann?
No, I think this is a great study, and the toxicity was really very manageable in the Nivo-AVD. And fewer than 1% of patients received radiation, I think, which was the other really important part, because pediatric patients and adolescent and young adult were also included, and many of those patients have traditionally been treated with radiation. So I think we're going to see this move forward. You know, the timing of its being listed, I think, is a little bit questionable. Whether it will happen before there's a paper out, I'm not sure. But the data certainly, I think, is very compelling.
Curious, Loretta, what your thoughts are about it. It seems a shame to get rid of, not bring in BV in some way. I'm surprised there wasn't a third arm, or somehow you have a very effective therapy that now you're going to have to, it looks like you're going to maybe have to choose. Any thoughts?
I think the fact that the study enrolled so quickly highlights sort of the enthusiasm in the community about potentially bringing the checkpoint inhibitor into frontline. And so I'm not disappointed about the fact that it's a positive study, and I think it gives us more options in the relapse setting.
Are there any thoughts about trying to integrate the two together into a regimen, Ann?
Yeah, there is a trial with Nivo, brentuximab, adriamycin, dacarbazine that's been ongoing. So yeah, I agree. I think if you replace the vinblastine with brentuximab, which is presumably going to be a much better drug, you should have even better results, I would think.
So before we go, Lowell has a case of a patient, interesting, a 911 survivor with Hodgkin. Before you get into that, just kind of curious, and just to refresh, it seems like we don't talk about checkpoint inhibitors that much because, all the attention's on up front. But any comments on the biology and why Hodgkin is so sensitive, with this amplification? Can you explain that, Loretta?
Sure. So what's unique about Hodgkin as opposed to several of the other lymphomas is the aberrancy with PD-L1 expression is much, much higher. And I think that's why with single agents in the relapsed refractory setting, we see very high response rates. What is encouraging to me is that when you partner it with chemotherapy, you don't lose that efficacy. And so I think that's what's quite intriguing. Now, the exact mechanism of what's driving the activity with a checkpoint inhibitor in Hodgkin, I think still not fully understood. And so that might play out a little bit more when we start looking for options in that relapse setting.
And Ann, I guess the other thing is in the post-transplant setting, we've had BV out there. I assume that's going to stay the same. What's your criteria for using BV maintenance?
So I use BV maintenance according to the ACERA criteria for early relapse, extranodal disease, or primary refractory disease. I think what gets complicated is if people had BV up front. I think it's very difficult to get a full year in. Those patients were not included on the study, and patients do get significant neuropathy. You often have to curtail it early. Yeah.
You're going to have a whole bunch of patients, though, who are going to have had AAVD and then get their transplant, and then who knows what the next generation will be. Lowell, let's hear about your patient.
Well, thanks. This is a case I do need some help with. She's a woman in her late 50s. She's actually was a 9/11 first responder. She was a New York City detective and got presumably exposed at that point. And later on moved to Florida, presented with stage 3 disease, but bulky 11-centimeter mediastinal nodes. So I started her on treatment. It was nice enough, the makers of BV were nice enough to let me get drug for her until we had coverage from the 9/11 folks, their commission. So I thank them for that. But we got her started on AAVD, and she did quite well. She actually just finished her, no major toxicities, finished up her full 6 cycles. I just got a new PET on her, which I called her about on Friday. Everything is down to Deauville 1, except the large mediastinal area there is still kind of a Deauville 2, and it was over 10 centimeters at the start. So I guess no neuropathy, no big problems, otherwise it's done well. So I guess my question really with her would be, would there be any role for consolidation radiation to the side of this bulk disease? And given the presentation, which you discussed so nicely today, would there be any role to giving her a checkpoint inhibitor now, or should I just watch and wait? So this is a very current case. I was speaking to her on the phone Friday about her PET.
Ann?
So a Dovil-2 would be a negative scan. We would consider that a complete metabolic response, maybe, and a Dovil-3 probably as well. I might, with a Dovil-3, get an interval scan, 6 or 8 weeks later, but I wouldn't consolidate with radiation, both in the Rathel study, even before the days of BV-AVD, we weren't using radiation in this setting. And,
Even if they had bulky disease
even
in
if
the
it was
chest?
bulky, yeah, and there were bulky patients in the Echelon-1 study. So as long as she's PET negative, I would sit tight, and she's likely to do well.
I hope so.
If she relapsed, that's when I would incorporate a PD-1 inhibitor, and what we're generally doing is going to pembrolizumab plus gemcitabine, vinorelbine, Doxil, based on data from Memorial Sloan Kettering. The response rates are extremely high, consolidate with auto. And then you can decide whether or not you want to add radiation at that point. Yeah.
Loretta, any comments about the case? Also, the 911 connection. What do we know about the types of cancers, the mechanisms? Any thoughts about that?
Yeah, I don't think we fully elucidated the exact mechanism that's driving it. We do see, whether it's with first responders or even young folks that have been in Afghanistan and other military scenarios where they were exposed to some of the burn pits, we do see higher rates of non-Hodgkin lymphoma emerging out of those exposures. Now, the exact duration of exposure, the lead time until you see the diagnosis of lymphoma, I don't think is clearly elucidated, so it's hard to know how we should do surveillance for those patients. That being said, I'm not approaching them differently in terms of management, and I agree with Ann. It is worrisome, the bulk of the disease, but you do have a negative PET, and so there's a good chance she might do well, and you could spare her the radiation late toxicity.
So another issue, and we're going to talk tomorrow night about the issue of attempting pregnancy in patients with breast cancer. Big study that came out of your place, Ann Partridge, there, showing that women could stop their hormonal therapy, attempt to get pregnant, and many had successful pregnancies. Lowell, you had a patient, I think it was a 27-year-old woman with an interest in fertility preservation.
Correct.
Can you kind of explain what was going on there? I'm curious about how you think through the issue of fertility in Hodgkin.
Yeah, it was difficult with her. She was, very interested in fertility preservation, which is in the non-academic settings, at least where I practice in Florida, is very, very difficult to get it's obviously easier for men, but it's very difficult for women to have fertility preservation, have anything covered, especially she comes from a somewhat disadvantaged socioeconomic background, so it's been very difficult to do it. She initially wanted to take no treatment whatsoever. I finally got her to see a radiation oncologist who I know is a good friend of mine, who's the same ethnic and background as her, and got her to explain to her that she could either have sort of mantle radiation, the old-fashioned stuff, or she could take the new treatment, which she did decide, and she reached. So one interesting thing was she just started BV-AVD, and I guess based on the new presentation, if you had somebody who just started, would you change them over to a Nivo regimen or continue with what you're on? I mean, every time we make a new advance, there's always these patients that just started on the old treatment, and then something new comes along that looks just as good or maybe better, and should we change them in mid-course or not? So I think that's going to come up. I'm sure you're going to be asked that question on Monday.
So, Ann, any thoughts about that? Also, one of the strategies used in breast cancer, and I think you can use in other cancer, is to give an LHRH agonist during chemotherapy to sort of put the ovaries to sleep, so to speak. Do you ever do that in lymphomas?
Yeah, so I would not change over at this point. You won't get it paid for at this point, and probably want to see a little bit longer term follow-up. With regard to fertility, BV-AVD has not been associated. ABVD has very, very low rates of infertility, particularly in someone who's 27.
Yeah, that's what I told her.
Yeah, so we don't generally do fertility preservation up front in those patients. I do put them on Lupron, and then if you give a progestin 5 milligrams back, you prevent the hot flashes. Many patients will feel better. I mean, you can kind of wait and then do it if they develop symptoms. The issue is then if somebody has primary refractory disease, then at that point I would pause and do fertility preservation if they need to go on to an auto, because, but it generally works quite well. And the other thing you can do is check an AMH level about a year after chemotherapy, because the thing I think we don't know is the chemotherapy bringing them closer to menopause or inability to conceive earlier. So if she were 35 and still not had children and wanted them at that point, you might do fertility preservation then as opposed to waiting until she's older.
So you would give them a little bit of progestin to help with the hot
The hot
flashes?
flashes, yeah, it works very well. Yeah.
I think there was actually a presentation at ASH the year before on successful pregnancies with women who had got AAVD.
Yeah, that's right.
So a few questions from the audience, and then we'll move on to diffuse large B-cell. Any reason right now to use Biacop in Hodgkin lymphoma?
No.
Can you discuss treatment options? Well, we'll hold on to that. What about using NAVD in earlier stage disease? Loretta, is that being looked at?
Yes, so there are probably much longer list of studies in the early stages, and it's going to be a little bit more challenging to navigate that as they all start to read out. But yes, all of the targeted agents are moving into combination strategies in frontline with the same expectations that you could potentially omit the radiation for, minimizing their late toxicity.
Are there trials? It was interesting that it was Nivo. Of course, we talk about checkpoint inhibitors all the time, and most people think there's not much difference between them. Are there trials going on, Ann, with the other, pembrolizumab, atezolizumab, et cetera?
Yeah, there have been other trials with pembrolizumab up front, both in early and favorable and advanced stage. I think a lot of it just has to do with, the big cooperative groups and which drug they can get.
So let's move on now and talk about diffuse large B-cell. And Priya, you had an interesting patient with the disease in the calf, in the leg. Can you explain what happened with that patient?
Yes, so she's a 72-year-old female presented with an ulceration, actually referred to me by a dermatologist for a non-healing ulcer, which turned out to be a diffuse large B-cell lymphoma. On staging, she did not have anything elsewhere, so this was pretty much the only site of disease. The bone marrow was clear as well. She got treated with R-CHOP, and interestingly, PET scan only goes to mid-thigh, so this is a calf lesion, so I had to remember to do a PET that's a whole body PET. And in any event, she has gone into complete remission. Her CNS IPI score was low, fortunately, which happens to be a risk factor in calf or skin-related, particularly lower extremity DLBCL, as I understand. Really wanted your thoughts about, just given the fact that this is a leg DLBCL, which is considered a high-risk lymphoma, what are your thoughts about Pola-R-CHP versus R-CHOP in this patient, even though her true IPI was not warranting it?
Loretta?
Yeah, really good question. So I presume this is a leg type, and generally speaking, those patients have high response rates, but higher risk of relapse. So I hear and echo your concerns about having less favorable outcome. It's a limited stage, and so with the POLARIX study, they, was more appropriate for advanced stage patients. So I probably would not jump straight to that yet, but I fully acknowledge those concerns. With the low risk IPI, with the low CNS risk, I think you could make the argument for 4 cycles of R-CHOP and nothing else. Though with the caveat of the leg type, I tend to do more combined modality therapy, so that might be one situation where I might add the radiation in as a consolidation, whereas if it was anywhere else, I might not.
So considering the fact that she had 6 cycles, and I sent her to the radiation oncologist who pretty much left it up to the patient to decide, who came back to me and asked what I would do, what are your thoughts about incorporating radiation at this point?
I'd probably just observe if she had a full course. It's not wrong to consider consolidation at that point, but then the question be, does she need it?
Mm-hmm.
So I'm curious about your thoughts about Pola-R-CHP. We now have the approval. I was curious what the approval was going to look like, whether there are going to be restrictions on it. You never know. We were talking yesterday, last night here in this room. There's a new approval in prostate cancer. Everybody's all upset because they didn't get it as wide as the trial here. And I wasn't sure whether or not they were going to restrict it. They didn't. And what's your thought about it? Is that a strategy you're using?
So I think we'll follow the study and give it in patients who have an IPI of 2 or higher. I think there's the concern that the drug may not be as active in the germinal center subtype based on the subset analysis, but the study was not powered to look at that. I think there's some additional analyses that will be coming out. I think it's probably a very good combination for the non-germinal center subtype, and if this patient had had a little bit higher IPI, probably would have been a great combination for her, but I think we're going to follow the data.
What's your experience, Loretta, and how do you find this regimen tolerability-wise?
Generally, I think it's just like our CHOP. Essentially, you're replacing vincristine with a drug that has a very similar safety profile. The only caveat in terms of lessons learned, it's a long first day because you have 2 antibodies. And so you have to prepare patients that they're going to be there all day. And it's probably better to see them on a separate day than the day you start them. But outside of that, I've not had any issues in terms of safety profile.
So we brought up the issue of CNS and diffuse large B-cell, and can you comment on where you are today in terms of CNS prophylaxis?
So as a group, we've decided not to do it. I think there are multiple large, retrospective, well-done studies that do not show a benefit. We have not been doing intrathecal for a long time. You get very poor penetration into the brain parenchyma, and if you're giving systemic methotrexate, you get much higher levels in the leptomeningeal space. But given the data that's out there, we as a group have stopped doing it. And it's kind of liberating, but it's a little scary at the same time when you see someone who has, renal or adrenal involvement or extensive marrow involvement. I think the key there is also to look very carefully up front to make sure you aren't missing occult CSF disease and to do brain MRIs and also to sample the CSF.
That's interesting. So when was it that you stopped doing?
We stopped doing it about a year ago.
I know there was an ASH about a year ago.
Yeah, it was based on the ASH, and then there's yet another.
Loretta, same thing?
Yeah, similar thing, though I will say that we do probably more aggressive surveillance than most centers, and so we're going to be watching those patients very closely as opposed to just observing them and then scanning in the setting of disease that's concerning for progression. We're proactively getting scans every 3 to 4 months for the first year.
So in a second, I'm going to ask Lowell to talk about his 60-year-old man, but I know you were watching the end of our session there in myeloma and us talking about bispecifics, so let's get into it here. I mean, one of the most exciting things going on in oncology in general, so maybe Loretta, you can provide a little bit of an overview of what the bispecifics are that are being looked at. We have one now approved. I think there's going to be more, what the difference is, and you heard us discussing the issues everybody wants to know. How are we going to deliver this?
Yeah, so back in 2002 when rituximab was incorporated with R-CHOP, we saw the improvement in overall survival. So it's not a big leap to expect a CD20 targeting antibody is going to result in favorable outcomes. The unique aspect is you have the CD3 targeting, and to be honest, I don't know that we fully understand exactly how it works, but it's an IV that's administered or a subcutaneous administration. You do a dose ramp up, essentially a small dose at day 1, a little bit larger dose at day 8, and then full dose by day 15 to try and mitigate the cytokine release syndrome. And the efficacy in 3rd line or later large cell lymphoma looks very good. So we have a new approval for epcoritamab, which is a subcutaneous administration. And in follicular, at the end of last year, we had an approval for mosunetuzumab. So I think we'll probably start to tease out what's our preferred bispecific. We anticipate there'll be more that come along with expanding that treatment landscape in large cell lymphoma. But I think there are some unique aspects about all of them that probably doesn't matter too much from an efficacy standpoint which one you choose.
What about tolerability and quality of life? And, kind of reminds me, Friday night we were in here talking about checkpoint inhibitors and lung cancer, trying to decide, is there any difference between them? And, for a while now, it's been hard to do that. Can you, at this point, start to dissect out differences? Sub-Q, that's certainly one difference, but maybe a little bit more flavor to the specific agents that are out there and what their profiles are.
Yeah, I think we're going to have to get more experience giving them in the clinic. I think that the schedules are a little bit different with mosunetuzumab, which we're using in follicular. It's more of a time-limited course. Particularly if they achieve a complete remission, you stop earlier. So I think and adding with glofitamab, they also get obinutuzumab pre-administration. So I think there's been a lot of discussion, I think, in the lymphoma community about how we're going to administer these agents and trying to get guidance and having a uniform approach in terms of, do you really need to give tocilizumab all the time, or can you just start with steroids? And, people I think are very, very nervous about this, but, the CRS is relatively low grade, and, we're sort of hoping that maybe we can get away with giving more steroids. And I think the learning curve will be steep, but I would think in a few months, I think we're going to feel much more comfortable with using these agents in the clinic.
Yeah, you probably heard Priya bringing that point up about the corticosteroids before. And you also probably heard Sagar talking about maybe bispecifics coming up front. Here you have a study looking at glofitamab plus R-CHOP. Loretta, do you think that's where we're going to be in the next couple of years?
Obviously, I think the natural progression is to move these targeted agents into earlier lines of treatment. The bar's a little bit high in large cell lymphoma. We had 2 decades worth of negative studies, so I'll reserve my enthusiasm until I see the results of the randomized study, but at least the phase 1 data looks reassuring that we don't see any new toxicity signals emerging. Efficacy looks reasonable right now, so I'm encouraged, but we'll have to see what the randomized data shows.
I want to talk a little bit too about CAR T, but also treatments available for patients not eligible for CAR T or post-CAR T. But let's get into another case. Lowell, you have a 6-year-old man. What happened with him?
Yeah, he's a practicing physician in town who presented about 4 or 5 years ago with a just rapid onset of bulky lymphadenopathy. It was a follicular lymphoma, sort of a higher grade follicular lymphoma. And he had R-CHOP times 6, went into CR. It was a very short-lived CR, I would say less than 6 months. He went on to he's from the Midwest originally. We sent him to an academic center there, and he went on a clinical trial with rituximab plus a experimental immune treatment. That worked for about 6 months. Then he came back to Florida, put him on R-squared, and that worked for, or a version of R-squared, because he'd had rituximab twice, so I switched out the antibody for Avina. And that worked also for a couple of years. He's been biopsied multiple times. He's still practicing, playing golf, and enjoying life. And his main problems now is lymph nodes that kind of grow and fairly quickly. When he progressed on this sort of modified R-squared regimen, we biopsied him again, and he has an EZH2 mutation, so he was interested in going on to tazemetostat. So we started him on that at full dose, and interestingly, he had almost a tumor lysis type response, a very rapid response with shrinkage of nodes, but had fevers, sweats, felt terrible. Now, there's a little kicker in there that he came down with COVID infection soon after that, so this may have been, one thing getting on the other at the same time, and he eventually got over the COVID. But we had to stop he was blaming it on the tazemetostat, but his nose is shrunken very nicely. So we left him on nothing for a little while he, improved his status. He had a couple of nodes that got bulky, so we gave them. He was very interested in getting a little bit of radiation because they were starting to bother him in his clinical practice. And interestingly, he had almost an abscopal type effect. We radiated a couple of nodes, and the other nodes started to shrink for a while. I have no idea why. But then I just recently started him back on Taz at he wanted to go on a lower dose, then I escalated back up. So he's on that now and doing pretty well. He still has had some pleural effusions, which we've tapped multiple times. They're always follicular lymphomas. I've biopsied his nodes several times, thinking that he must be transforming, and he's not. So he's still in a follicular lymphoma. We just recently sent him. I was thinking that he might, need a Pleurix type catheter and stuff, but there's not enough fluid. So I think he's responding again to the Taz. So I've been very interested in trying to talk him into something, and he's seen consultants all over the place, even at one of your places that you folks work. And so I'd be very interested in finding out what would be, if your recommendation would be just to keep him on the Taz for as long as, because he's progressed on everything up to this point, so I'm sure he's going to progress on this at some point. Or would you go to something like either a bispecific or CAR T at this point, if I can, if he's willing to do that?
So I didn't want to interrupt you, but you got two 60-year-old patients, and I meant you to do the diffuse large B-cell, but that's okay. It's a great case.
the other
That's
one.
okay, no problem. Let's stick with this one. We'll come back to the other ones. It's a great case anyhow. I was thinking, you take care of a lot of doctors, but okay, that's the patient.
Yeah, the other one's not a doctor.
Yeah, okay. So anyhow, no problem. We're talking about bispecifics. Any thoughts about this? Sounds like maybe somebody may be thinking about mosunetuzumab. I don't know. What do you think?
Yeah.
Yeah, I think you've done a great job with him. You know, it sounds like years of, I mean, this is classic for follicular lymphoma. And yeah, I think mosunetuzumab, you know, you could think about CAR, but I would probably, it sounds like he wants to keep working and, you know, you're not going to lose anything by starting with mosunetuzumab. It's not myelosuppressive. Yeah, I think that, but you may want to ride out the tezemetostat as long as you can get a response.
That was kind of my thoughts, too.
Yeah.
Loretta, what is your experience with tazemetostat? Do you use it in EZ wild-type patients? What do you find in terms of tolerability? Any thoughts?
It's very well tolerated, as you've probably seen. I agree. Probably some of the toxicity you're witnessing may be related to infection more so than the drug itself.
Yeah.
You know, we don't have a lot of experience because we have so many trials that we're trying to recruit, but I have used it in EZH2 mutant, not wild type, but it's a reasonable option if you have no other good options because the toxicity is going to be so favorable. There's some interesting data emerging from the Cornell group using it as a way to sort of optimize your auto T cells. And so I actually like Ann's idea of introducing Mosun probably before he starts to progress pretty rapidly, because you can use that sort of tumor microenvironment effect of the tazemetostat to augment that T cell engaging, and that's probably why you had an abscopal effect with the radiation if it wasn't too long of a gap in between. So I think we're going to get more experience with how to sequence therapy in follicular lymphoma, and there are features of tazemetostat that make it attractive in terms of the impact on the microenvironment.
Can you dissect out the abscopal thing a little bit more in terms of what you think is going on?
Yes, so there's a study underway right now looking at tazemetostat in combination with lenalidomide and rituximab with the idea that you're augmenting the T cell phenotype in addition to impacting the follicular lymphoma cells directly. And so you're skewing it towards a more environment that's not going to be as favorable to the tumor and is going to potentially be augmented by adding in lenalidomide. So we know with radiation you can actually also generate antigen exposure. And so again, now it's a very short half-life, so I don't know what the time lapse is, but we're using it right now to expose patients to tazemetostat and then collect T cells. The Cornell group is doing this with the idea that you're going to have a healthier, more fit T cell to then build the CAR in. And so I would imagine that same principle can be applied to a bispecific.
What's your experience with mosunetuzumab, Ann?
We're just getting started on it, but so far it's been, you know, so far so good.
What do you see with the first dose? Because I've heard even the first dose isn't that much of an issue.
Well, the very first dose that one of my colleagues gave was to a patient who had had a near anaphylactic reaction to rituximab. So he had the similar response. So it was not a good way to start with our, you know, all our colleagues getting worked up about, you know, everyone was so nervous about starting this agent. But I just started a patient last week, and you know, I think generally you don't see a response, a reaction until the third dose. But my patient's doing well so far.
Loretta?
Yeah, I agree with that. I think Mosun probably has one of the most favorable safety profiles, and so though you do see CRS during the first cycle, it's generally grade 1. I think the tricky part is having enough clinical experience when we know to just react with Tylenol versus corticosteroids versus when we need to tell patients to present to the emergency room. We'll get better at that as we gain more experience, particularly predicting those grade 1s that are going to progress to grade 2 or higher CRS.
Any comments, Loretta, on CAR T and follicular?
I mean, obviously, I think it's a very effective strategy. I think the challenges are what you highlight. There's so many options available for these patients. It does require referral to a specialized center. They have to be away from work for a minimum of 4 weeks. You have all the challenges with the manufacturing. And so I'm using it in select patients, but it's those patients that I'm concerned about transformed disease. I just haven't proven it, either with a biopsy or for those patients that are progressing really quickly through very effective therapy and they're young and fit and they're going to tolerate the toxicity.
All right, well, let's flip back to diffuse large B-cell. Well, you had another 60-year-old patient. Can you present that person?
Yeah, the other patient is interesting because especially this goes back to our discussion we had in the myeloma session a few minutes ago. This is also a Jehovah's Witness who is 60-year-old, presented with non-germinal type diffuse large cell, got R-CHOP, had a response, and probably about 6 months later, he was in CR. 6 months later, began to relapse. I was initially, what I've been told, at least from our transplant centers in my state, is that there is no role for autografting in, or no ability to autograft the Jehovah's Witness patient. So he started on Pola-BR, which he's doing very nicely on at this point. But I guess the question is, after I was talking to Dr. Lonial in the myeloma session a minute ago, and he tells me he transplants people's Jehovah's Witnesses all the time, just gets their red cell count up before the transplant, and they do great. I don't know if that's true in diffuse large B-cell or not, or if people would go to anything else.
Ann, I see you shaking your head. You have a bloodless program there?
No, I was thinking that, he relapsed early, so he's someone I would think about CAR T for.
Yeah.
And I would think, those patients often don't need transfusion, so I think it would be safe in a Jehovah's Witness. We've done a couple of patients with auto transplant, but the question is going to be whether the T cells are going to be fit after the bendamustine. I don't know how many cycles of bendamustine.
He just started. Yeah, that's a good question. How much BR Pola could he get if he's going to try and keep his cells okay?
Yeah, I would drop it and just give the Pola R and try to get the patient referred to a CAR T cell center.
Okay.
How do you decide what comes first, CAR T or bispecifics, a diffuse large B cell?
I think it's going to be really challenging. I think it depends on where you practice. So if you're in a center that can deliver CAR T and it's not a big deal, you're going to choose CAR T first because of the long-term results and the durability in about 40% of patients. If you're in a community setting, I don't actually have a problem with you trying a bispecific and then quickly getting them to a CAR T center if that's not working.
For patients who aren't eligible for CAR T or transplant, can you talk about how you sequence therapy in relapsed diffuse large B cell? You have Pola-R-CHP, Tafa-Len, Lonca-T, selinexor. Can you kind of comment on that, Ann?
So I think the bispecifics are really going to change how we approach that at this point. I tend to use Pola-R. If I know someone is not going to be eligible for transplant or CAR, I will add in dose-reduced bendamustine. I do think you get better responses. And then I will usually go to loncastuximab next. I think the tafasitamab lenalidomide data hasn't really held up as well as one might have expected. I think that the patients who were enrolled on that study were not primary refractory for the first part of the study, and I think they were just a lower risk population. So if I had an older patient who had a late recurrence, then I would definitely try Tafa-Len, but it's also, it's an onerous schedule. People have to come in, very frequently for infusions. I've had some good luck with loncastuximab. Selinexor, I've only honestly used a couple of times and have found in large cell lymphoma patients not terribly tolerable, even with the weekly dosing.
Yeah, I think you maybe heard the myeloma. They struggle with that in the beginning. It seems like they figured out a way to do it. At least the investigators say they have. Priya has a question, but before you bring that up, what's your sort of formula in the non-CAR T, non-transplant eligible patient, Loretta, in terms of sequencing, and where do you think bispecifics are going to fit in there?
I actually do think bispecifics are going to change things dramatically. The one caveat is understanding the CRS and how do you manage it and how do you keep patients out of the hospital. So it may take a while before we see that actually permeate. But I generally approach it very similar to what Ann has mentioned. If I have a CAR T patient, I'm going to avoid tafasitamab prior to CAR because it's an antibody that's got a longer half-life that's going to mask that epitope. Or I might use something like Lonca, where it's going to get internalized, it's really chemo delivery. So I kind of view CD19 a little bit differently in terms of the mechanism of action and how long it's going to stick around. I don't have an age cutoff or a frailty limit for CAR T, but I'm a CAR T center, and so everybody's a CAR T candidate in my mind. It's just how and when do you use it, and which CAR do you use? And so I do think bispecifics are going to fit a need. It's going to be first in that post-CAR failure space, but it's probably going to take over in the front line for those higher risk patients that probably are never going to get to CAR.
Any comment, Loretta, on the difference in the CAR T preparations available, which ones you use and which ones you'd like to use in what situations, and also what's being done to try to improve outlook?
So the problem right now is axi-cell is very reliable, and so in our center at Anderson, it's utilized about 99% of the time. And so with aggressive lymphoma like large cell lymphoma, that predictability of I'm going to send cells off, I'm going to get a reliable product tends to outweigh the safety profile because, again, the intent is cure. In an ideal situation for my older, frailer patients, Lysocell would be more readily available and more dependable in terms of manufacturing because I do think it has a better safety profile and the efficacy looks pretty good. I think the challenge right now with T-cell is you had a randomized phase 3 study that was negative, so you can't unknow that information. And so our perception is that the efficacy is lower with that. So there still is an unmet need. And so what we're doing to try and address that is, are the allogeneic CARs going to be able to address that manufacturing delay that happens, particularly for those bulky, highly progressive tumors that you just don't like having to wait? The question in my mind is whether or not the efficacy is going to hold up, particularly as it pertains to durability, but that might change things if that really can challenge. And then in other scenarios like follicular mantle cell lymphoma, where it's not quite as urgent, I think we have more of an appetite for trying things other than axi-cell or axi-cell-like.
You said theoretically anyone is a candidate for CAR T, so otherwise in good condition, no age limit?
There should not be, no. Now, you know, with axi-cell, you do have higher rates of neurotoxicity and cytokine release syndrome. That's grade 3 or higher. So for our older, frail patients, we do a prehab where we have them meet with physical therapy. We start trying, just like you would do for an auto transplant, to try and optimize them to reduce their risk. But the treatment-related mortality is incredibly low with CAR T, particularly in the first 30 days.
Ann, any other comments?
We tend to, I agree, I don't think there's an age cutoff. We tend to use Lysocell in the older patients, knowing that sometimes the product's out of spec and we have a trial that we can enroll patients on to get them the product. But I agree, we use a lot of axi-cell given the very reliable manufacturing.
Priya, you had a question?
Yeah, 3 questions. So what is your preferred bridging therapy prior to CAR T? That's number 1. Do you want me to go over all 3?
Yeah, let's see if they can remember them all. This is like a cognitive test.
When you give Tefalen,
You're not allowed to write it down, Ann. No, just kidding. Just kidding.
do you dose reduce Len? Because that seems to be quite a bit of an issue in how you do it. And third is, I noticed you said hold Benda with the Pola BR. Is that something you're doing routinely?
Ann?
Yeah, so if we're giving, if we're even thinking that CAR's on the horizon, we do not give Benda. So we use Pola-R as bridging fairly commonly once we've collected the cells. I think if people have really explosive disease, you may think about using chemo, but generally we would do the Pola-R.
All right, well, let's go on and talk a little bit about mantle cell. And Priya, you have a patient with a mantle cell. Can you, I guess, who actually he ended up dying, but he did receive a treatment, and including R-CHOP, DHAP, and then acalabrutinib. Maybe we can just talk about him as a case and get into the issue, particularly of the BTK moving up front in the 2 trials we've seen, trying to figure those 2 out. So Priya, let's hear about your patient.
Yes, so he was a 59-year-old gentleman with mantle cell lymphoma. I started his treatment along with communication with our transplant team. Started him on R-CHOP and DHAP, alternating therapy. He went into a CR. He did not have health insurance for whatever reason. He did not get upfront transplant. He actually did well. 2 years later, he relapsed. And it's a low-grade progression, just lymphadenopathy. Started him on acalabrutinib. He had a very good response to it, which lasted about a year, and subsequently developed more bulky lymphadenopathy. At this time, I switched him to bortezomib and rituximab. He got admitted with pneumonitis, which the pulmonologist seemed to attribute to rituximab. Regardless, he was very sick and unfortunately passed away from a respiratory failure. However, thinking about him back now as far as treatment, let's say if he did progress on bortezomib and rituximab, or even after acalabrutinib, at what point would you either go to pirtobrutinib or transplant?
So we now have pirtobrutinib approved in mantle cell. And can you talk a little bit, maybe we'll hold off the two upfront BTK trials for a second and deal with the issue of sequencing of therapy in mantle cell, and particularly where, again, we were talking about CAR T, where CAR T comes in, and also which BTK inhibitor you prefer.
So I probably would have done CAR T at the progression on acalabrutinib. If, sometimes those patients can have, if you stop the acalabrutinib, their disease can really accelerate rapidly. So I usually leave that on. You can always add venetoclax on top of that to try to sort of temporize things while you get them to transplant if the disease is becoming more aggressive. And then, sorry, I forgot the second question.
I forgot too, but...
Oh, BTK, which BTK? I like zanubrutinib, honestly. I think it is an incredibly well-tolerated drug. I have 90-year-olds who are on it. Sometimes I end up reducing the dose. I had a 90-year-old who liked to do planks, and he came in with his arms were completely black and blue. And we dose reduced him because he kind of pushed for it, and his disease control was great. So it's just, acalabrutinib is a very good drug also. You get the headache issue, which is relatively common. And sometimes if you have a patient who's kind of, reticent to go on a medication and they get these bad headaches, you can just avoid that with the zanubrutinib. So I've really begun to favor that drug, yeah.
And what about pirtobrutinib?
So pirtobrutinib, I'd like to see more data because, it's just been approved. I have someone who's on compassionate use and really not seeing a response yet. So I really want to see in the broader sense outside of a clinical trial. The response rates were relatively good, I think in the 50-60% range, but the CR rates were relatively low. And I don't know, what the quality of those progressions were on BTK. Were they patients who just sort of slowly marching along, or are they people who are a little bit more, aggressive progressions?
Loretta, same questions. How do you sort of sequence things, and where does pirtobrutinib come before or after CAR T?
Yeah, this is one disease where I think we are going to learn a lot more in the next few years. And so I don't have a good sense of what my preferred approach is now. But this is a young patient. I would have done the same thing. You give him intensive chemotherapy with the intent to go to transplant, and then I would have applied maintenance post that. But now things have kind of been thrown on its head. We've got the triangle data, which we'll talk about, but the question now is, should you do transplant, yes or no? Do you do maintenance, yes or no? I generally do a BTK inhibitor as my second line approach, and now you've got multiple BTK inhibitors. And so I agree with Ann, I generally have been going to acalabrutinib or zanubrutinib just because of the safety profile. Now you've got pirtobrutinib, which is a little bit different mechanism of action. Maybe you're going to have less resistance emerge. The efficacy looks a lot better in the BTK naive versus those that are BTK exposed. But I also have that in my back pocket that if they fail zanubrutinib or acalabrutinib, I can potentially go to that and address the issues that Ann raises. Sometimes they fail really quickly, and so you're going to be getting them to that next thing, which generally is CAR T. And so pirtobrutinib might be a good thing to have in my back pocket if I need a BTK inhibitor. And then where do you do venetoclax? Do you pile it on? Do you sequence it? Again, more questions than answers.
Any thoughts about venetoclax combinations? Any thoughts about that, Loretta?
I mean, the efficacy looks really good. I think we have to see the randomized data to know if it's better. You're going to have more risk in terms of infection, so it's going to be a little bit of a trade-off. You're going to get good efficacy. You're going to have potentially higher risk. But again, we have a randomized study that's underway, so we'll see.
All right, let's take a shot at SHINE and TRIANGLE. I think you need to be a Talmudic scholar to understand those two trials, but Ann, can you kind of make it simple for us?
Well, so the SHINE trial added ibrutinib to bendamustine plus rituximab versus the combination without. And there was a progression-free survival benefit, but there was a lot of toxicity, and there was no overall survival benefit. And my understanding was, looking at the toxicity data, there was a discussion with the FDA, and they opted to pull the approval for mantle cell lymphoma. The triangle data is very interesting. So patients were randomized to standard of care, which would be induction, chemotherapy, autotransplant, and then maintenance became standard sort of midway through. So some got maintenance, some didn't. And then they compared that to adding ibrutinib in the upfront, in the initial setting, and then afterwards. And then there was the third arm was the ibrutinib arm without the transplant. So we know that if you add ibrutinib compared to
with or without the auto transplant. It's better with ibrutinib. The question is, do we need the transplant at all? And I think that's the part that is still, the data was not yet mature. So the question is, should we be giving patients a BTK inhibitor up front? There's a lot of controversy on this because I think most of us would not use ibrutinib at this point, given the toxicity profile. And can you extrapolate to another BTK inhibitor? I think probably you could. And do you really need the transplant? And I think probably we don't. But I think it is not, how this is going to be taken up in the community is not 100% clear to me at this point.
I don't know how it's going to get taken up by the two of you, so let me ask you right now, outside of a trial setting, how do you approach a young patient with mantle cell?
So we are still participating in the intergroup trial that asks the question, if you're MRD negative, is there a benefit to transplant? So we sort of committed to that trial, and I think that will be important data to have. The majority of patients are MRD negative, so it's going to be very interesting to see that. And now with the data that's being presented on Monday, the overall survival benefit with maintenance rituximab has disappeared in the longer term follow-up. We need to see the presentation to really delve into that data more, but that adds yet another layer of complexity. So I suspect in the future we're going to use combinations with a BTK inhibitor, probably without transplant. And then in second line, I think that's a very appealing trajectory, because then in second line we're going to have either bispecifics like glofitamab with obinutuzumab looked very, very good, or we have CAR T. So it's kind of nice not to take someone to transplant, because if you do a transplant and then you do CAR T, we see a lot of patients who end up with cytopenias that are persistent or even MDS.
So again, Loretta, how are you approaching young patients with mantle cell? And I didn't even know about this maintenance thing. Is that going to change your approach to maintenance?
I think it does make it a little bit harder to do the RDAP, RCHOP alternating, because what we had traditionally done is do that for your young fit patients, auto transplant, 3 years of maintenance rituximab, because it was such a compelling story. You had a PFS, an EFS, and OS advantage. The OS has disappeared now. Transplant has raised questions. So I think generally the easiest answer is we should probably do studies, throw out the rule book and start all over, and probably the targeted therapies are going to win out at the end of the day because they're quite effective, they're pretty well tolerated, and I think most patients would rather do that than intensive chemotherapy, knowing they're still going to potentially get those targeted agents down the line. I think the challenge to that, though, is they're young patients, they're going to live a long time. What happens when we use up our BCL2, our BTK inhibitor in front line? Well, we've got CAR T in second line, but what happens when they fail that? Now that's an unmet need.
Do you see the plateau with mantle cell the way you see it with diffuse large B-cell from CAR T?
Yeah, but the curves don't look the same. So with large cell, you drop off in the first 3 months and then you plateau. Mantle cell is a little bit more like follicular, where it's kind of trickling, but it is still much better than anything else we have in that setting. And it does look like it's sort of plateauing with very small numbers out, 3+ years.
All right, well, we're going to move on now and talk about CLL. Thank you so much.
Thank you.
So we're going to talk about CLL. In a second, I'm going to ask Priya to present her 68-year-old woman. Well, welcome Drs. Allan and O'Brien up here. All right, well, we have our general medical oncologist here to present cases to you, and we're going to start out with Priya Rudolph, has a 68-year-old woman. Can you tell us about her, Priya?
So 68-year-old female, very good health, no comorbidities, presenting, whom I've been following with CLL for 2 years now. Her lymphocyte doubling has been rapid upswing trajectory with more bulky lymphadenopathy, so she needs to start treatment. And now that we have zanubrutinib approved, the question comes up, do we use acalabrutinib, do we use zanubrutinib? There was a recent MIAC comparison, statistical comparison between the side effects of zanubrutinib and acalabrutinib, and it seems like there is higher hypertension and bleeding risk, perhaps, with zanubrutinib compared to acalabrutinib. What are your thoughts on, based upon that, and I know it's not it is cross-trial comparison, however, just given a very high incidence of hypertension with zanubrutinib compared to even ibrutinib or acalabrutinib, would you say in somebody with comorbidities, including hypertension, prefer acalabrutinib? How about bleeding, with that being slightly higher? Again, cross-trial comparison with zanubrutinib, would you prefer acalabrutinib, say, on someone who's on anticoagulation, or you think is at a high risk for bleeding?
So that kind of just leads into the whole topic of first-line therapy. Also, the issue of efficacy. You know, is zanubrutinib more effective than acalabrutinib? So, John, can you kind of paint a picture of the way you see first-line therapy, and also the option, assuming if you could access it, of a combination of BTK plus venetoclax? How do you think through your strategy in patients who require treatment, John?
Yeah, so I think this is a scenario that we commonly see, and we're stuck with three, honestly, really great drugs, and now we've got two that are more second generation. This hype of, you know, maybe less toxicity has now technically been proven in head-to-head studies, and we do think of second gens when we're starting a BTK inhibitor. You know, I think, yes, we see, I guess I like to rephrase it that, you know, these are BTK inhibitors, and in fact, there are class effects. And, you know, we cannot get away from bleeding, we cannot get away from hypertension, we cannot get away from arthralgias, regardless of the drug that you're using. And you will see it if you have enough patients and you're using any of these agents, you will see these side effects. Now, with the second generation drugs, I do, in my own experience, you know, and the data has shown that, you do see less of these kind of events occurring. You know, when you talk about hypertension, is that an all or nothing kind of question? A hypertensive patient who's on one agent and maybe it's 150, you know, systolic, you know, that's not somebody that I would necessarily say, oh, you can't use zanubrutinib for, that you have to use acalabrutinib. You know, the rates of hypertension with acalabrutinib at 40 months and the head-to-head study was 9.5%. In the Alpine study, it was 15% at 30 months. So it's not that you get away from it, and maybe it's less there. You know, I guess when I look at a patient who has coming in, they're at 180 systolic, they're on 3 agents already, maybe maxed on 2. Maybe in that scenario, I think of using a drug that has technically maybe the less hypertension there, but by no means would I consider not using zanubrutinib even. You know, I think in general, that type of patient, I'm starting to think maybe they're not a BTK inhibitor type of patient. And so that's kind of where I see that. It's not this all or nothing just because they're hypertensive, because you still see the side effects. They are still there. You cannot get completely away from them. And, you know, bleeding, yeah, it looks, again, maybe a mildly improved percentage, lower percentage having bleeds. And, you know, but this is one of these things that when you need an anticoagulant and you're on a BTK inhibitor, you know pretty quickly if they're going to have problems because they'll start to bruise and these types of things. So, you know, in that scenario, if I start to see the bruising on the inhibitor, either I'll talk about dose reduction. Sometimes that helps. In my experience, they're still bruising and it doesn't necessarily take care of the problem. That might be a scenario where I may try to talk about switching to a different agent depending on which one is causing the bruising. But again, that's another scenario where is that even a BTK inhibitor patient? I see it more as a class of agents rather than Xanu versus Acala. And frankly, we don't have the head-to-head data of those two agents. Yes, these indirect comparisons are somewhat helpful, but in reality, we can't make too much inference from it. And, you know, there's still advantages, potentially once-a-day dosing versus twice-a-day dosing, other toxicities, headaches that you don't see. So I don't have the right answer. You know, I don't think that just because you're hypertensive, you can't use these agents, particularly if it's a patient with 150 and they're on amlodipine or something like that, let's say. I mean, that's where it is. But, you know, so that I don't know if I can tell you which drug is absolutely the best, because right now we don't have that data, honestly, to say. And it comes down to some patient preferences and a little bit of experience and trial and error once you start and choose one for the specific reason. And
we want to get into the issue of also BTK versus venetoclax, but let's just stick with choice of BTK. And I'm curious, Susan, what your thoughts are, not only about the issues John was just discussing in terms of, you know, side effects, et cetera, but efficacy. You know, zanubrutinib looked like, it was reported to have greater efficacy than ibrutinib, which you didn't see with acalabrutinib. Any thoughts about whether that's real? Any point at this any preference right now about BTK?
I mean, it's not an easy answer to give. I totally agree with John. We have two different randomized trials where acalabrutinib was non-inferior to ibrutinib and zanubrutinib was better. Not exactly the same patient population because the acala trial was relapse high risk, all 17p11q. The Zanu Alpine trial was all comers. But nevertheless, clearly Zanu was better than ibrutinib in an all-comer relapse population. Now, the next question is it reasonable to extrapolate that to the front line? I think you could make a rationale for that. On the other hand, you always get your best results, right, in any leukemia the first time you treat somebody. So if you're going to have generally better results the first time around, will that, maybe you can extrapolate that data. If you actually look at the PFS curves for the Sequoia trial, which was the frontline Zanu trial, for Resonate-2, which is the ibrutinib trial, and Elevate-TN, and you only look at 2 years, because we only have 2-year follow-up for the Sequoia trial, the numbers, the PFS are identical. But you could also argue that's too short a follow-up. If you might see a difference if you have longer follow-up. There's another little bit of a ringer in there, which is there's a small paper that was published suggesting that unlike with acala and ibrutinib, if patients become resistant and they develop a mutation, it's not the CIS481, rather it's more of a gatekeeper mutation, which could potentially render them resistant to pirtobrutinib. So obviously, all of us, we don't have yet Pirto and CLL, but we're really looking forward to having that as another BTK option when our patients develop resistance on the covalent inhibitors. It's not a huge series. How robust is that data suggesting that the mutation profile is different and might not allow you to use pirtobrutinib? That's another thing that's I think about when I'm thinking about starting frontline. I certainly agree with John that to some extent you're going to get all of those side effects with all of the drugs. I think the only one that has a very specific side effect is the headache with acala. But my experience with that has been it's very mild, responds to anything, including caffeine, and is very short-lived. So I've never had to stop treating a patient because they got a headache. So other than that, I think there's a lot of class effect here, as John said, and it just varies a little bit from drug to drug. So I think as John said, you have 3 really good drugs here, and we're lucky to be, and they obviously are very good, because we wouldn't be parsing every little thing if they weren't all good. If one was so clearly the winner compared to anything else, we wouldn't kind of be having these long discussions about how to choose.
I want to get into also the issue. I'm sorry, you had a question?
Oh, I just wanted to add that something that I think about when choosing a BTK is also the fact that acalabrutinib only has 1 dose and it has to be twice a day. There is no data to show once-a-day dosing, whereas ibrutinib, you can dose reduce. Acalabrutinib comes in, I think, 70s, so you can use lower dose if you want to. And that's something I do think about. If I have a patient who I'm afraid they're going to come up with side effects, I will think about something that I can potentially dose reduce, because acala you can't.
Although I have heard people, John, talk about using acala once a day. Do you ever do that?
Yeah, so it's a great point that you bring up. I think we don't have, so ibrutinib has actually developed a lot of data of dose reductions and several kind of retrospective looks from various groups have shown that the 280 dose doesn't necessarily or lower impact a longer term outcome like PFS or OS. Ibrutinib also has weight-based dosing that we know BTK occupancy at 2.5 mg per kg gets you above 90%. So we know kind of what level you have to be. If you're a 90-year-old frail patient, you don't probably need 420, honestly, to have that 90% BTK occupancy. We don't have weight-based dosing with the other BTK inhibitors. I think, yes, acala is this twice-a-day dose. I think we have antidotes that we have patients that refuse to take it twice a day, or they tell us that they are not very compliant with twice a day. They're taking it once a day, and they're 5 years later, and they're progression-free, and they're doing well. So I think that data is important to potentially generate and try to understand a little bit better. It's nice to have multiple levels to potentially dose reduce when you think about it. Zanubrutinib, again, this is a drug that seems to have really high Cmaxes, and if anything, has different PK than the other two agents, where you can get very high plasma concentrations. And probably from our ibrutinib understanding, we probably don't need to actually have all of that to have this efficacy, honestly. And so if there are side effects, I am now, based on this ibrutinib data, much more quick to dose reduce, to keep patients on a specific agent before I switch. I think that is not necessarily just an ibrutinib story. It's probably all three of these agents, and maybe more so with ibrutinib and Xanu, just because there are multiple dose levels that we have that. But by no means do I think it's wrong to go to once a day. We just haven't understood that, and anecdotally speaking, I have had patients on once a day are very not compliant openly and still doing well. So again, yes, that can factor into which agent you want to use. And again, it comes down to this physician comfort, because we don't have the answer. We don't have good data to really definitively state one way or the other that these are going to be these outcomes based on these dose reductions.
Interesting that you're mentioning ibrutinib. I'm curious for both of you, when was the last time you started somebody on ibrutinib, Susan?
I don't start people on it anymore.
And you, John?
I don't.
So, and this also gets into the issue of time-limited therapy. And Eric, you have a 57-year-old woman I want to hear about. But first, Lowell, when we were chatting, one of the things you said that really struck me, I hadn't heard, is that people you think people in the community are hesitant to use venetoclax. Can you comment on that?
You think people are what?
Hesitant to use venetoclax.
I think yes. I mean, the community setting for the average patient. I think there's still worry about tumor lysis, the ramp up, and that sort of thing. So I think it's. If I had to guess, I would guess across our practice it's probably a little bit underutilized. We did in our phase 1 unit, I used to be involved with our phase 1 trials, we did some very early studies with venetoclax when it was a phase 1 drug before we really knew about tumor lysis. I remember my colleagues saying, whoa, this, so you have to know how to use it, obviously. And I think there's a learning curve, but it's not as simple as starting somebody in a BTK inhibitor.
So again, before we get to Eric's case, Susan, in what situation would you like to be able to use a combination of venetoclax and BTK? For example, just an unmutated young patient, for example.
Right, well, we have the data from the Gaia trial or the CLL13 trial that's been presented. I think if it's not just out in New England Journal, it's about to be out. And that was the 4-arm trial. One arm was chemo, one was Ven-R, one was Ven-G, and one was IVG, so the double small molecule.
Yeah, that was in the New England Journal.
And so far, with about 3 years of follow-up, both the MRD undetectability rates are, as well as the PFS, is very, very similar between Ven-G and IVG. So is there any advantage, and that also raises the question, if you're going to use 2 small molecules, is the antibody going to add? I don't think we know the answer to that. But would there be any advantage of, if they're producing roughly the same outcomes of IVG over VG? My answer would be no. Is there an advantage, let's pretend we can extrapolate from IVG to just IV, is there an advantage there? Maybe if you want to avoid antibody therapy, right? If your patient doesn't live close by and they have to come from a long distance to get the antibody, it's much nicer if it's all oral. And then we also have data, COVID is still there. It's not going away for the immunosuppressed patients, that if you get an antibody, that's the one therapy where you are not going to respond to any kind of a vaccine. But again, if it's IVG, you've got the G in both arms, and right now the Ven-G and the IVG look the same. So, and we have more long-term data for Ven-G. So the simple answer to your question is, I don't see a big advantage for IV right now, but that changed my mind with more follow-up.
John?
Yeah, so I think this is something I was heavily involved with. We were both involved with the Captivate study, which was IV in young patients. And so I do have a lot of experience using the combination approach. And do see MRD negativity patients, and I have several that were randomized to placebo because many of them have now been unblinded and are MRD negative and they're 4+ years out. I've seen patients have MRD relapses, but they are completely in an asymptomatic state, and it's literally a low-grade MRD relapse and are still doing well without a second line of therapy. So one thing that I think I used to think that we were going to fixed duration, all oral therapy. There is all these advantages of this avoiding anti-CD20, at least what we think, and maybe what we'll see even on Monday or Tuesday with Dr. Woyak and that the Alliance study. From infection standpoints, that I thought there was going to be this advantage and that everybody was going to do it. This was going to be the new fixed duration for everybody. And then we started to see this signal where the mutated IGHV patients actually had lower CRs and actually got to MRD negative rates at lower rates. And that has been shown at multiple different studies now. And so there's something biologically. Is that because the duration of therapy is incorrect, or that's biologic? And if those patients got another 6 months, they convert to these higher rates. So this pendulum has swung back for me to say it's maybe not right for everybody. And kind of where I use it in my clinical practice currently is Dr. Al-Sawaf of the CLL-14 German CLL study group has now published a recent update about a month or so ago looking at biological features, who is identifying that's going to do inferior with Ven-G. And what he found was that del-17p and bulky disease greater than 5 centimeters are patients who have inferior PFS. One thing from Captivate that we have shown is that even if you had bulky disease, you had MRD rates and CR rates that were similar to those patients without the disease bulk. So that is in del-17p patients. So that's the one patient population, a bulky patient or high-risk disease features where I do think combination therapy has some value. The problem is it right to stop those patients ever, right? Is that a fixed duration, or is that just a way to optimize an MRD negative state in a really high-risk patient, which you can argue has a lot of value? So that's where I'm doing it, and if they're young and they're MRD negative, I feel comfortable to stop them. If they're del-17p complex karyotype, I'll have that conversation if they can get there. But that is kind of where I am using the oral combination without the anti-CD20. I'm not convinced it's adding a whole lot. It does seem to tick up the MRD negative rates a bit, but I've come kind of, my pendulum is swung back saying it is probably going to be for a select group probably, and definitely not something for older patients, 80-year-olds. I don't think they need that, honestly, this maximal therapy.
Eric, let's hear about your patient.
Sure. I have a 57-year-old female CLL, very well controlled. She's been taking acalabrutinib for about 2 years. No real side effects. Had the initial headaches, controlled with caffeine. But asked me, do I have to take it forever? I mean, that was the original plan. And now that we have regimens that are time limited, and I guess I'll expand upon the question now that John talked about MRD. Would it be appropriate for me to check an MRD for this patient? Or would it be appropriate for me to switch the patient over to a time-limited regimen, venetoclax, CD20, ibrutinib, venetoclax, something like that, if the patient truly wanted to stop? And again, would MRD make a difference in your decision?
Susan?
So I think that's a very interesting question because I've often thought that maybe the way we use the BTK inhibitors is actually not ideal. And what I mean by that is we know that when patients become progressive, they're obviously resistant to the BTK inhibitor because they become resistant while they're on it. And nevertheless, the frontline remissions are very durable. But we have data from the ECOG trial, the FCR versus IR, where it looked at the patients who had to go off IR for toxicity. And most of them had been on about a year or a little longer, so they enough time to get a decent PR. And the median time to progression, which is not necessarily the median time to next treatment, right? Because if you progress with a lymphocyte count of 7,000, who cares? The median time to next treatment, to progression, was 2 years. So it's occurred to me, what if we left patients on a BTK inhibitor for, and I'm making up the number, 4 years or 5 years, and then stopped. And then if they took a bunch of years to progress, but we could go back and use the drug again, would that actually be more attractive? So I have had patients who've said to me, usually before they go on, I really don't like the idea of taking this therapy forever. And what I've said to them is, look, I'm willing, not in 3 months or 6 months or even 1 year, I'm willing to sit down with you at some point and discuss just stopping. My bias would be stop and don't do anything, not necessarily change to another therapy. Wait till the time that they progress, and then if they really are more interested in fixed duration, move to a fixed duration regimen then. So that's, now have I actually ever done it? No, because most of the patients who've queried me up front, well, wait a minute, do you think I could actually stop this, have not actually come back to me yet and asked to stop. The other point you raised is, would we ever see MRD undetectability? And I have looked numerous times on people who've been on it 4, 5, 6, 7 years. I personally have never seen it. I wouldn't be surprised if there's some case somewhere, but no, I don't think you're likely to have MRD undetectability.
But you would consider stopping them anyway if they're under good control after a few years, even if they weren't completely MRD?
Yes, I would. I wouldn't necessarily go to them and say, do you want to stop? But if they came to me, yes, and I would be comfortable doing that, yes.
One question about pirtobrutinib. First of all, are you able to access it in CLL, John?
So off-label, I have inquired, and I have been successful once to look into it as an off-label for CLL.
Susan?
But I've had many other times in our group where it has been denied.
It seems surprising. I mean, it looks like it's very effective post-BTK. What do we know about that, Susan?
I haven't tried to get it for any of my patients, so I don't have experience with it, but I've heard, as John just stated, that it's not easy.
What about the cardiovascular profile of pirtobrutinib, John? What do we know about that? I can recall a case presented in one of our webinars of a patient who'd had VFib and really bad heart disease and couldn't get venetoclax. What do we know about pirtobrutinib in terms of cardiac safety?
Yeah, so I've personally actually never used the drug. The patient who I actually got it for has been on the fence of what he wants to do. But so I did not have the study, so I've not used it in a clinical trial. But everyone who I've spoken with speaks to the data, and they state it's a well-tolerated agent. You have to always take it with a grain of salt. This follow-up time on Bruin is a year now, so with follow-up time, more AEs can accumulate over time. But even at the 1-year follow-up in the CLL group, I think AFib rates were less than 1%, and the few people that developed that actually came onto the study with AFib already. So I don't think we're seeing a lot of incidence of it. I do think there is, you have to keep in mind, it's a very selective BTK inhibitor, and obviously the reversible nature may have just as much to do with it, more, or maybe even more, just it being so selective may be this low AFib rate. So it's probably both components of the drug that makes it special, but it does seem to be very well tolerated, has low rates of these cardiac toxicities, and I think that's a strong advantage of using the agent and potentially into the future, even for intolerant patients.
I'm curious in terms of the issue of upfront therapy, time limited versus not. Susan, this has really entered the consciousness of medical oncologists the last couple of years. When I talk to people, I hear people thinking more about it in younger patients, yet I wonder whether older patients are just as interested. How do you go about sifting through, the basic way you're going to go BTK versus venetoclax?
For me, a lot of it is the prognostic factors. So what I mean by that is if they're mutated, if you look at the CLL14 trial data, the VENG, we have 5 years of follow-up. We'll get 6, I think, at EHA next week. If you look at the PFS for the mutated, at 5 years, it's about 80-something%. So in other words, they're doing incredibly well, and that's 4 years off drug. So in my mind, mutated, I'm much more leaning towards going to fixed duration therapy. In the opposite group, the least good group, if you will, 17P, P53, I much more like the idea of continuous therapy. So I lean way more towards the BTK inhibitors in that high-risk population. In the unmutated, I think you could go either way. We know with VenG, the unmutated had a shorter PFS than the mutated, but it was still about a median of 5 years, which still gives them 4 years off therapy. So that's pretty good. But we know that there's no difference in outcome, at least on Resonate-2, by mutated and unmutated. That means that the unmutated, technically with ibrutinib up front, are having longer PFS than they would get with VenG. But again, it's with continuous therapy versus stopping. And also remember, there's always the thought that, well, if you stopped Ven and X years later they relapse, you can probably go back to it. So to me, the two clearer groups in my mind are the best group and the worst group, and then the unmutated are kind of in between.
So, John, what do you do with patients who have a positive MRD at the end of 1 year? And again, I'm curious about how you see time-limited therapy, specifically VenG and the older patient. I hear a lot of people immediately thinking about, they're giving the BTK inhibitor because they're 85 years old. Is that kind of that you're thinking also, or do you think venetoclax is also a good option for older people?
Yeah, so to answer your first question is MRD and using it to make some treatment decision. I think what our data has shown us is that if you're MRD negative and you're thinking about a fixed duration, it's okay to stop. Dr. O'Brien was stating, in del17P patients, do we do that yet? Do we feel comfortable? I think we don't have the data really to direct us one way or the other. The flip side of this is really the only way to actually use MRD to make any treatment decision and outside of just stopping therapy, and that is to look at the MRD positive patients, and if you're MRD positive, how do you manage them going forward, and can we convert them? And so we don't have any data there to say, we need to treat patients specifically in this manner. We have evidence growing that you can extend therapy. Captivate has shown that an additional year of ibrutinib venetoclax did increase the peripheral blood MRD negativity rate. There's been several studies that have shown kind of this improvement in sensitivity over time. So maybe it's not fixed duration, it's treat to some response. And now we have studies, several of them are ongoing, where they are actually incorporating treatment decisions based on MRD positivity. Not necessarily the negative patients, they stop, but the positive patients are now being treated differently with either additional therapy, add-on therapy, zanubrutinib, ibrutinib, the MAGIC study, acalabrutinib, they all have some variation of looking at modifying therapy based on an MRD positive status. So I think we can get there, and that's really the true way to incorporate MRD, is to use it for the positive patients and then choose it, because I think what we've learned is that if you're negative, prognostic, and it seems pretty safe to stop those patients outside of these rare high-risk ones.
I was just flashing all the discussions going on in solid tumors about cell-free DNA. Same kind of strategy in terms of developing trials. So speaking of cardiac issues, Priya, you have a patient in his mid-70s who developed atrial fibrillation. Can you talk about him?
Yes, so a gentleman in his mid-70s with CLL who was, back in the days, started him on ibrutinib. He developed atrial fibrillation. Subsequently, his cardiologist put him on a pacemaker as well as anticoagulation. He did well for a while until, unfortunately, he developed GI bleed, and then he went continued on ibrutinib. However, in the midst of all this with COVID, he unfortunately passed away. Shortly before then, he developed a stroke as well. So my question is, if somebody is on one of these BTKIs and develops atrial fibrillation, say for instance in this particular gentleman, and may have had a complication with that, say for instance a CVA, would that be a reason to switch to another BTKI? Of course, we can't use pirtobrutinib as of now, but how about acalabrutinib or zanubrutinib?
So Susan, before you discuss this, actually Eric, I was just flashing on the fact You presented a case in one of our webinars of a patient, I think he developed atrial fibrillation in another country or something. What, do you remember?
Yeah, he was on ibrutinib and he traveled to Poland and he developed atrial fibrillation over there. And fortunately, he had my contact. So the doctor from Poland actually called me and I said, oh no, it's medication related. And they were able to get him on a beta blocker and he came back to me and I actually switched him off of the BTK inhibitor. So that was, at least he knew who to call.
International cooperation. Yeah. So Susan, patients who have a history of atrial fibrillation on anticoagulation, how do you think about using a BTK? People like Priya's patient who developed atrial fibrillation on BTK, how do you think it through?
I haven't switched anyone to another BTK inhibitor because they developed AFib on ibrutinib. As John said earlier, to some extent this is a class effect. My thinking would be, well, if this patient is inclined to develop AFib, it's just a guess that they may get it on another BTK inhibitor because they've already declared themselves as someone who has a tendency to get AFib. So I haven't necessarily taken them off either. But if I really felt compelled to take them off, I would be thinking much more to switch to venetoclax-based therapy.
What about, how often do you see bleeding? This patient had an upper GI bleed, and does it matter what kind of anticoagulation they're on? Susan?
I mean, that was looked at. There was a big series a number of years ago looking at the incidence of bleeding with, it was ibrutinib, and whether it went up with anticoagulation. And it did go up, but it wasn't a huge jump. It was numerically, it was definitely higher in patients on anticoagulation, but it wasn't huge. I mean, I think a big concern to me in an elderly, frail patient is falls. So that's where, if they're on anticoagulation, I would, if they're 60 and fit on anticoagulation, I'm not going to worry about it that much. If they're 80-something and they're frail, yeah, I'm really going to worry about it because I'll keep thinking what happens when they fall. So it's a little bit, so I don't think of the whole group the same. I think it's very much dependent on the probably age/frailty or non-frailty of the patient population.
So Eric, I want to hear about your 65-year-old man who got ibrutinib and then venetoclax, rituximab. I want to talk a little bit about how people utilize venetoclax, which anti-CD20. Let's hear about your patient.
Sure, absolutely. 65-year-old man had a very good response to ibrutinib, was on it for about a year and a half, then developed worsening cervical and axillary lymphadenopathy. I actually had an excisional biopsy done a real Richter's transformation. It wasn't, it was just SLO. And so at that point, I actually transitioned him over to venetoclax plus rituximab. I started rituximab first, and about a month later added venetoclax on. During the ramp up for venetoclax, he ended up with tumor lysis syndrome. The creatinine didn't rise too high. I think it was like less than 2, but his uric acid was 10.5. I actually gave respiricades in my clinic and brought him in for hydration, and it resolved. He actually did not need hospitalization. And so my question for the investigators would be, if you had a patient who was well controlled, this patient was not well controlled, he is clearly a refractory patient, but if you had a patient who was well controlled and you were switching over, would you need to do the ramp up dosing for venetoclax because they don't have big lymph nodes or high white blood cell count? And the second question would be, now that we have some data for pirtobrutinib for BTK refractory disease, would that be something you would try to get before you would switch over to venetoclax plus another agent?
John, I'd like to also hear what your thoughts are about choice of anti-CD20, particularly in the relapse setting like this patient. And again, how also what you see in terms of correlation between renal function and having TLS.
Yeah, so I mean, I think this patient brings up a lot of interesting conundrums and issues that we have to deal with, and how do we manage a high-risk patient. So anyone who's progressing kind of in this accelerated CLL scenario on a BTK inhibitor is in a danger zone for sure. And this is not somebody you want to kind of stop the drug and then wait for, a week and a half to get your venetoclax delivered. And by then things can really take off and get away from you. So I agree, kind of having them kept on it and then starting the rituximab to start to kind of cool off the disease and bringing in the venetoclax. I think your question was, if you have a really low risk patient, do you have to do this monitoring? And I think it was along those lines. And do I modify the ramp up at all? So I don't generally. I kind of stick by the rules. I say to the patients, it's an investment of these 5 to 8 weeks, and once you're through it, it's safe. You play by the book, you're going to stay out of trouble. The flip side to that, though, is when these high-risk patients who are progressing on the BTK inhibitor, I do frequently actually bring them into the hospital and can get them accelerated ramp up, like over a week or so. It takes hospitalization, it takes monitoring very strictly, but in these truly high-risk patients progressing on a BTK inhibitor, there is some imperative time is of the essence kind of scenario to kind of get to an effective drug level quickly rather than over 5 weeks, because rituximab may not kind of buy you that much time. And that brings up in this other question you're talking about, the anti-CD20 to use. I generally use obinutuzumab almost solely and wholly for CLL, regardless of a setting that we're in. We've got multiple clinical trials that show obinutuzumab is a superior agent over rituximab, usually in the frontline setting. All of that data is in the frontline setting. But I do think that there's probably some advantage of using what we know is the best agent. Probably it's going to be a better agent in the relapse setting, particularly in these higher risk patients. And if they've seen anti-CD20, they've had chemotherapy or something like that and are progressing in a true relapse setting, and they haven't seen it, then there may be some advantage to it. Now, that's all, there's no data with obinutuzumab really in a relapse setting to state that it's better with venetoclax in that, like in the Murano. But in general, I do use it and extrapolate it to regardless of the setting that they're in. It does cause more problems, though. You also have to deal with the cytopenias, infection risks, and things like that. There is slightly higher rates of those with obinutuzumab.
Susan, do you use the CD20 to debulk the patient to lower the risk for TLS? Start out with obinutuzumab, debulk them, and then give them the venetoclax?
No, I'll tell you exactly why.
Because they get TLS on the obinutuzumab?
No, yes, and the problem is I can't really do obinutuzumab inpatient because the pharmacy will lose their minds.
Right.
But I can do venetoclax inpatient because the patient brings their own supply. So, but it's exactly what you just said. I've seen some rip-roaring tumor lysis with obinutuzumab, and I don't want to start with it in the outpatient setting. I just don't like it. So I actually start with ven, and if they're high risk, I just admit them, and where they can have really intensive monitoring for tumor lysis. And then I add the obinutuzumab on later, actually, is how I do it when their risk for tumor lysis is lower.
Oh, interesting. I could talk about CLL all day long. I swear there's never two cases that are the same. They're always fascinating. Lowell, let's see if we can squeeze in a couple more cases here. Lowell, otherwise healthy man in his 80s.
Well, yeah, this question is just about the other side of CLL. When do you start to pull a trigger to treat somebody? This is a guy that I've been watching with observation with, just gradually increasing white count over a number of years, has had no treatment. Now he's at the point, he's in pretty good shape. He's in his mid-80s, fairly active for a Florida guy. White count kind of went up 20,000, 40,000, 60,000. Now his platelets are going down, okay? So he's feeling the same. I'm setting him up for a scan to see if his spleen's getting big or something else is happening. So assuming that it's not just from progressive splenomegaly, is that count enough that we would start him on a BTK? He's otherwise asymptomatic, not having terrible infections, no change in his quality of life. It's just a numerical thing that we're seeing. And this happens quite a bit. We're seeing it in the clinic, so as the numbers change. And I don't treat them just based on the white count, but what about the drop? What about the increasing thrombocytopenia?
Susan?
I mean, I think of it, so would that be an indication for therapy? Much more so than the white count, in my mind. However, the one point I would make is that you would want to make sure this is an ITP, right? So if he's having autoimmune and it can respond to steroids or a short course of rituximab, then you may not need, and he has no other indication for treatment, then you may not need to treat him.
I was thinking the same thing. Maybe I'll just start him on some prednisone.
Exactly. That's what I would probably do. How low is the platelet count?
80,000, not bad. He's not bruising. He's not really bleeding or bruising. I was thinking actually of doing that and giving him a test of prednisone.
Can you talk a little bit, Susan, about when you start thinking about actually treating the CLL for autoimmune cytopenias as opposed to rituximab steroids?
Sorry, say that again, Neil?
How do you decide between using rituximab and steroids versus BTK inhibitor, venetoclax, treating the underlying CLL?
So the way I kind of think about it is if the cytopenia is out of proportion, so, someone with a white count of 40,000 that has longstanding disease and now their platelets are 50 and their hemoglobin is really good,
Right.
15. To me, that's very likely to be an autoimmune phenomenon. So it is hard to tell. I don't think antiplatelet antibodies are very accurate. I agree with what you just said. I would tend to say, I'm going to test it by giving them prednisone and see what happens. The platelet count shoots up, I have my answer. Now, not everybody with ITP responds to prednisone, so if that doesn't go up, it still may not be completely clear. But what makes me really think of it is if that cytopenia seems disproportionate to the total volume of the disease.
All right, let's see if we can get your thoughts a little bit on Richter's transformation. In Priya, you have a man in his late 70s.
Yes, a 78-year-old gentleman with CLL. Initially started on ibrutinib. He had myalgia, so I switched him to acalabrutinib. He was doing really well, but progressed on it and switched him to venetoclax. Then got admitted in the hospital with bulky lymphadenopathy, feeling poorly. He literally crashed within a few weeks' time, I want to say 2 or 3 weeks, and unfortunately never even made it out of the hospital and passed away. So thinking back, and we certainly see Richter's transformation has happened very, very fast. Given the rapidity of the disease, and now, hopefully we'll have pirtobrutinib approved in this setting, does pirtobrutinib work fast enough to get a response? Should these people still be treated with chemotherapy? What is the preferable choice, assuming pirtobrutinib is approved in the setting?
So, John, I guess it was ASH where we saw I was really surprised. It seems like nothing works with Richter. So what are your thoughts about Priya's questions?
Yeah, monotherapy, BTK, pirtobrutinib, they have data, shows good response rates. These responders seem to have decent remissions, et cetera. I just caution, we saw a similar thing with acalabrutinib where monotherapy approach with acalabrutinib a few years ago. The PFS, when you look at it, is still like months and weeks and months for the vast majority of these patients. So one, it's very important to talk with your pathologist and make sure that this is truly a Richter's transformation. If you know things about the biology, is it clonally related? Can you match up these IGH translocations? Because if it's clonally related, progressing truly on a BTK inhibitor and then venetoclax, I don't think, again, I haven't done it, I haven't seen it, that monotherapy is out there. It's probably not going to be enough to get you to a CR and get you to, the next more definitive therapies, bispecifics, CAR T cells, et cetera. And yes, they're probably not going to respond super well to even chemotherapy. That's kind of what we still use. That's still what we use for a true Richter's clonally related, progressive, rapidly progressing patient, is to treat them. We have a study looking at polatuzumab with our EPOC or our EPCH. That's on study for newly diagnosed Richter's transformation. So we're studying this to see can we optimize and make our therapeutic initial approach a little bit better. But I think the goal, if they're fit and relatively young, is still to try to get to some more definitive remission for a more advanced therapy, whether that's allo, if they're very young and they've got matches, versus even CAR T cell approaches. And fortunately, now we have bispecifics that are approved in DLBCL. It's not in Richter's, but Richter's is typically a DLBCL. So these are new options that are going to be at play for us. And while I think using Pirto is an approach to get the approval a month later after fighting the assurance and all these types of things, this is somebody that you don't have a month to wait for, really, and you do need to get to more aggressive treatment. And typically, a true clonally related Richter's, I'm giving chemo as the induction.
Do you see responses to CAR T with Richter's?
The data, so OSU has put some data out there using kind of commercial product off-label for Richter's, even though it's DLBCL, so technically on-label, and the responses look good and similar to what we've seen in de novo DLBCL in those settings. So I think it's a great option and better than usually these patients are not in CRs, they have PRs, they have active disease left over whatever induction, and we know those patients do horribly if you're taking them to allo. So this is a nice consolidation approach that might be able to clean up this residual disease, whereas allo is really not really able to do that.
Susan, any thoughts about Richter's both on and off trial? Any trials that are exciting to you?
No, I think the good news, Priya, is whatever you do is fine because everything stinks, is the moral of that story. Mm-hmm. So you can do whatever you like. But so I agree with John. I think the two things that we're most interested in, but for which there's woefully little data, is CAR T and bispecifics, because it's a large cell lymphoma, because those agents look so good in de novo large cell lymphoma. Most of the times Richter's is excluded from the trials. It will be interesting because I don't know about the one that's already approved for large cell, but the one that's coming from AbbVie, they will have a positive, their label also says transform lymphoma. So I'm wondering, given that it does say transform, but it says lymphoma, not CLL, would we be able to get that off-label for Richter's? I don't know. I've never tried to do it. But I would say the things we're most interested in is the bispecifics as well as the CAR for Richter's.
Any final questions from our oncology panel?
The one question, relapse setting, assume again we have pirtobrutinib. Would you favor that to venetoclax over for BTK progression?
John?
Yeah, so I typically I'm holding Pirto as kind of for the true double refractory patients. You know, I don't know if we've seen enough good long-term data of a true progressor on a BTK inhibitor going to Pirto. They were in the study, but they weren't those patients had BTK inhibitors, but may not have been the prior line of therapy going into that study. So I think we have limited data there and understanding what does that PFS look like. We know good venetoclax salvage data. You can get them to MRD negative states. And the PFS is at 2 years in a monotherapy approach. And so it looks historically better than what we saw with what we're seeing with Pirto and double refractory and prior BTK inhibitors. So I still tend to favor it to kind of be this salvage for these double refractory patients, or at least that's where I can conceive it in my practice. And if they're Ven naive, I think I'd have a hard time selling going to Pirto unless there's some toxicity issue, unless they're not able to come in, the creatinine is elevated, they can't tolerate a fluid load. Those are things that could come into play.
So our one final question, Eric?
Oh, just a comment. I think it was Epicorumab that was approved for follicular, including low-grade and also transformed follicular as well. So that's something that...
I think it was diffuse large B-cell.
Yeah, for diffuse large B-cell lymphoma, but it also, I think they allowed for follicular lymphoma as well. So maybe that was the indication, maybe the transformed lymphoma as well.
Interesting. So John and Susan, thank you so much, and particularly to Lowell, Eric, and Priya for working with us to develop this. Thank you for attending. Come back tomorrow morning when we talk about bladder cancer, 6:45 a.m. Have a great night.